Thank you all very much for having me. Thanks to MedStudy for inviting me to give this talk. Dr. John Van Cherry, who was one of my mentors in residency, had done this talk for a number of years, then offered to see if I wanted to do it, and I was more than happy to. I used MedStudy to study for my PEDS boards, so I was very happy with the results. So the outline for our presentation, we're going to go through the organisms first, so you can identify what organisms are, and then we'll go through kind of what they do and some syndromes they go with. So again, review of pediatric infectious diseases in a very, very, very short. It seems very short, but really to y'all it's going to be very long because it's all flipping afternoon. So I apologize. So first audience response question. As a participant listening to my talk, are you a resident, a faculty member, a non-physician learner, or a Michael Bolton admirer? So in full transparency, as a co-director, my co-director and I, Dr. Roy, have our residents do this, and so there are a number of our residents in the back. So there should be at least 9 answers for D. Oh, okay. Wow. That's fantastic. Faculty member, resident. Okay. So you're supposed to know your audience when you give a talk, so I just want to make sure I know the audience. There will be no singing at any point during this lecture. I will make fun of people every now and then, but only because people make fun of me for my name, but I will be very gentle and whatnot. And if you're looking for a Michael Bolton concert, he's apparently performing somewhere in Mississippi in a couple of weeks. So gram-positives. Next audience response. 14-year-old female presents with fever, chills, and a history of flu a week ago. Now she has a cough and left-sided pleuritic chest pain. A chest x-ray has left lower lobe pneumonia, and blood culture show gram-positive cocci in clusters, as suggested there on the screen. What is the appropriate antibiotic to begin for this patient? Oral amoxiclav, IV vanc, IV ceftriaxone, IV ampicillin, IV vancomycin, and piptazo. Okay, so most said IV vancomycin, scattering of oral amoxiclav and ceftriaxone and AMP, and then some vanc and piptazo. Okay, so the correct answer is IV vancomycin. And the reason for that mainly is because of the positive blood culture that it told you about. And so whenever you have a positive blood culture showing gram-positive cocci or GPC, you use vancomycin. And in this particular case, this was a kid who had a post-influenza staph pneumonia and likely bacteremia. So ceftriaxone, vancomycin is the drug of choice for that. Oral amoxiclav has no staph coverage. IV ceftriaxone has no staph coverage. IV AMP has no staph coverage either. And you don't need the piptazo because you know that it's going to be a gram-positive, and you have vancomycin there to be sufficient for that. So gram-positive cocci. So Staph aureus, MSSA, and MRSA. There's coag-negative staph, and there are lots of different coag-negative staphs, but for the purpose of this, we're talking about coagulase-negative staph, mainly staph epi. Strep pneumo, also known as pneumococcus. Strep pyogenes, also known as group A strep. There's strep agalactia, also known as group B strep. There's group C and G strep, and enterococcus, formerly a group D strep. So Staph aureus. So what can Staph aureus do? It can cause impetigo, right? So superficial skin infection. Its most common cause for osteomyelitis and septic arthritis. It's seen in individuals who have IV drug abuse, so whenever you see that on your test, think about staph. People who are on dialysis, sometimes their catheters can be affected by Staph aureus. Toxic shock syndrome, staph can do that, as well as group A strep. You can have a severe skin reaction, epidermal necrolysis. You can also have a brain abscess, notably in cyanotic congenital heart disease kids. Shunt infections, so whenever you see a shunt infection like a VP shunt, think of coag-negative staph and think of Staph aureus. And then a history of recent flu and new onset pneumonia, just like the vignette we had, think of Staph aureus. So an illustration of what impetigo or multiple abscesses can look like. Usually staph are going to have purulence. Staph will have purulence as opposed to group A strep. So MRSA in the blood, vanc is the drug of choice for exams. If you see gram-positive cocci suggestive of staph or Staph aureus in the blood, you want to give them vanc. If you have a gram stain that has GPC, you give them Vanc, because Vanc will cover for staph. It'll also cover for your streps. Your trough you want to aim for is 10 to 20. You want to measure that around the 4th or 5th dose. We no longer use Gentin rifampin for synergy. The only exception would be prosthetic valve endocarditis, and we'll talk about that in 1 second. For kids who are at least 8 or older, we can use daptomycin for MRSA bacteremia. It's a great drug whenever you have persistent MRSA bacteremia. If vancomycin does not do the trick, or you cannot get to your appropriate troughs, even though you're going to about 40 mg per kg for therapy. When you have MRSA pneumonia, you can use Vanc or linezolid. The nice thing about linezolid is that it has much, much better lung penetration than vancomycin does. And it's going to be, and you're going to assure that you have coverage for MRSA using linezolid. So either one. You don't use dapto in pneumonia because it's inactivated by components within the lung itself. And so we don't use dapto for MRSA pneumonia. So microbiologic complications of bacteremia, namely with staph. And so as we talked about brain abscesses, especially in cyanotic congenital heart disease, you can have preseptal cellulitis due to Staph aureus. You also about orbital cellulitis or postseptal cellulitis. Staph can be included in that as well. There's the pneumonia. You can have endocarditis, particularly if you have hardware. You can also have perinephric abscesses due to Staph aureus and group A strep. There's osteomyelitis. You can also have vertebral osteomyelitis due to staph, septic arthritis, osteomyelitis, pyomyositis. All of these things can be due to Staph aureus, in particular MRSA and MSSA, along with thrombophlebitis where the IV is going in. So again, skin soft tissue infections. The treatment we use for staph, empirically at least, is usually clindamycin. We can also use trimethoprim sulfa or TMP SMX, doxycycline, or linezolid. The nice thing about Clinda, and the nice thing about linezolid is that not only does it cover staph, it covers strep, namely group A strep as well, another common cause of skin soft tissue infections. If you use TMP-SMX or use tetracycline, you might want to use either penicillin or amoxicillin to cover for group A strep. If they're hospitalized, then you use IV vancomycin. The D test that you note up here is on clindamycin, and so every now and then I'm going to do my best when I give residents lectures. I tend to ask them why and expect an answer back. I don't think we do that in this form. So if I ask why, it's not really rhetorical, but it has to be rhetorical. I'll try to answer the question for you. So I would say, what's the D test, Dr. Hamner? But the D test is where you look for if you're going to induce resistance to clindamycin based on a gene that's present within staph. And so we can't use Clinda for very long term if they're D test positive, meaning that if you give them Clinda, there can be inducible resistance over usually 2 weeks' time. So whenever you see skin, soft tissue, bone joint, skin, soft tissue, bone joint, no matter really where it is, you want to think of staph, the group A strep. Skin, soft tissue, bone joint, group A strep, Staph aureus. Coag-negative staph, so mainly staph epi is what they're going to give you on your boards. It's the most common cause of catheter-related bacteremia and bacteremia in patients with a foreign body surgery. So for coag-negative staph, chances are we have to do something to that patient for them to get a coag-negative staph infection. If you have a blood culture that's positive for coag-negative staph and it's someone who has a fever but they're otherwise healthy and don't have immune system dysfunction, chances are that's a contaminant, unless they're in the NICU or they're severely ill and you have repeatedly positive blood cultures for coag-negative staph. Otherwise, it has to be some sort of hardware that we give to the patient that gives them coag-negative staph. The drug of choice for coag-negative staph is vancomycin. Every now and then when you get sensitivities, you can use something like nafcillin, but that's few and far between. Strep pneumo, also known as pneumococcus. The big thing for exams is resistance, and so typically if you have strep pneumo, the drug of choice is penicillin. However, if you have intermediate resistance to penicillin, the drug of choice becomes a third-generation cephalosporin, and that would be something like ceftriaxone or cefotaxime. If it's highly resistant to penicillin, then you use, again, a third-generation cephalosporin, such as ceftriaxone or cefotaxime. Plus minus vanc, it sort of depends on the type of infection that they have. Usually the more severe, such as CNS disease, you want to use VANC. If they have meningitis, you use VANC plus a third-generation cephalosporin until sensitivities on strep pneumo are known. And we'll get this a little bit into the common ID syndromes about what you use for bacterial meningitis, and it's usually going to be VANC and ceftriaxone until you know the organism that you have. Strep pneumo is the most common bacterial cause of otitis media, meningitis, pneumonia, and occult bacteremia without a focus. The predisposing factors that is going to make you think that this bug could be resistant include going to daycare, if they have recent antibiotic exposure, recurrent otitis, or if they're less than 2 years of age. And you want to use high dose amoxicillin because the idea is that overcomes some resistance whenever it's in otitis media especially. So you do the high dose amoxicillin. Okay, question 2. A 4-year-old male presented 1 week ago with chickenpox. 1 day ago, he developed fever, sore throat, and chills. He is delirious on arrival. He presents to the ER with hypotension, conjunctivitis, a red macular rash with desquamation of the palms. His coags are out, his creatinine is 3, his platelets are 20,000. His blood culture grows an organism in 8 hours. Which is the most likely diagnosis? Severe varicella sepsis, Epstein-Barr virus, toxic shock syndrome due to E. coli, toxic shock due to strep pyogenes or group A strep, or toxic shock syndrome due to Staph aureus. Okay, so everybody was on the right ballpark for the most part, right? Toxic shock due to either group A strep or Staph aureus, and we'll talk about why group A strep is the correct answer. Part of it is the association historically of varicella infections with group A strep superinfection, and so that's part of it. We'll talk about toxic shock and then group A strep versus Staph aureus toxic shock. So there are different criteria that you need, and usually you have to have a fever, a pretty decent fever of at least 102. One thing I would recommend, learn your Celsius to Fahrenheit calculations. Sometimes the boards, they like to be Celsius, even though we typically don't think of things in Celsius, and we don't report temperatures in Celsius really in the medical field, but on the boards they like to give Celsius, so make sure you know the Celsius conversion factor a little bit. At least 40 degrees Celsius is 104 Fahrenheit, and 38.9 degrees Celsius is 102. Just a little tidbit. Hypotension for age, rash with subsequent desquamation, and usually the desquamation happens 1 to 2 weeks later, not usually upon presentation. You usually have the rash first and then you desquamate. Involvement in at least 3 organ systems, so GI, so usually diarrhea or vomiting, muscular, so really bad myalgias, you can have an elevated CPK, mucous membrane, so like a strawberry tongue, renal, so acute kidney injury, liver, where you have an elevated ALT, usually twice upper limit of normal, blood, where you have the thrombocytopenia, and central nervous system disease, where you have altered mental status. And then theoretically, you need negative serologies for Rocky Mountain spotted fever, leptospirosis, and measles. Most of the time, clinically, we don't get those because it looks like toxic shock syndrome, so we typically don't look for leptospirosis, measles, and Rocky Mountain spotted fever. But from a strict criteria standpoint, you need that. If it's post-surgical, you want to remove implanted device, because the idea is that could be group A strep or Staph aureus causing the toxic shock. So again, this is strep pyogenes causing toxic shock. Staph toxic shock is often associated with menstruation, and blood cultures are usually positive in strep, group A strep toxic shock, not in staph. And so for the vignette we had, our kid has a positive blood culture grow in 8 hours. So a positive blood culture more than likely is going to be group A strep and not staph. Treatment for toxic shock, if it's staph, use VANC, presuming that it's MRSA. If you know, if you get a culture from an abscess or wherever the infection might be coming from, and you can identify an MRSA, you use VANC. You use nafcillin, because nafcillin is much better for MSSA. VANC will cover MSSA, but it's by no means, it is actually inferior to nafcillin to cover for MSSA. So MSSA, you need nafcillin or oxacillin or first-generation cephalosporin like cefazolin. Just to give clindamycin, mainly for, it helps with toxin mediation, and then you plus minus IVIG. It depends on how sick the child is. And I say sick, you would think that toxic shock syndrome, they're always sick, right? They have shock syndrome. But there's actually some degree of spectrum about exactly how sick they are and how many measurements or how many criteria they meet within those guidelines of toxic shock. For strep, you give high-dose penicillin and IV and clindamycin plus minus IVIG. And if there's evidence of necrotizing fasciitis, you want immediate surgical debridement because you need really good source control to prevent the continuation of the inflammatory response and toxin mediation that happens with toxic shock syndrome. So moving on to group A strep, also known as strep pyogenes. So everybody loves it as a cause of pharyngitis. Even if you're 6 months old and have a positive strep, that's pharyngitis apparently due to group A strep. It's not. It was tongue in cheek. Impetigo, strep toxic shock, which we just talked about, rheumatic fever, glomerulonephritis, and scarlet fever. So pharyngitis, you typically need to be febrile. You usually have tender cervical adenopathy. You have exudative tonsils. The rapid strep is point of care is usually really good. Or if that's negative, you then have to follow it with a throat culture because the sensitivity of the rapid strep tends to not be quite as high as needed per lab guidelines. Treatment is penicillin for 10 days, or you can do a single dose of IM penicillin. Things that are not strep, cough, rhinorrhea, symptoms of URI. If you have a runny nose and a cough, that is not strep, so there's no need to test for strep. Kids, like toddlers, can get a group A strep infection, but it doesn't typically show up as strep throat. It shows up as streptococcosis or streptococcal fever, which is where you have a thick, purulent nasal discharge, low-grade fever, and some emesis. Scarlet fever, you typically have pharyngitis with the rash. The rash typically tends to be sandpaper in quality, so you can usually feel the rash, and it feels very rough like sandpaper. It's prominent in your flexor skin creases, and the treatment is the same as pharyngitis, so penicillin, PO. Clinically, so on your boards, treatment is penicillin. In real life, penicillin tastes awful for those who've never had penicillin, and so sometimes you might get better compliance in your 5-year-old kid who refuses to take penicillin, give them amoxicillin, which tastes so much better. The residents can attest to how awful penicillin tastes. So in the middle, that's the sort of the what they call pastilla lines that you can see in the flexor creases of group A strep, strawberry tongue on your right, and the rash on your far left. Again, just additional rash for scarlet fever. Erysipelas is another group A strep infection. Really, it's basically where you have infection of the underlying connective tissue due to group A strep, and the skin is exquisitely tender. One thing that separates it on your exam is that you're going to have a well-demarcated line between infected skin and uninfected skin. And so sort of seeing here, you can see in the top picture or sort of toward the back where there's a well-demarcated line of where the infection is. Same thing on the middle picture where it's sort of near the groin area where there's a clear line of where the infection is, and same thing on the bottom picture. So that's erysipelas. Sometimes clinically it's hard to distinguish. On the test, they're going to say you a well-demarcated line, or they'll show a picture of a well-demarcated line of an infection, and that's erysipelas due to group A strep. Again, this is exquisitely tender, and so they'll usually mention that in the vignette. Necrotizing fasciitis, again, this is one of the causes that we typically see with toxic shock syndrome. It's really cellulitis gone bad. You have severe pain. You have severe swelling. This is also known as the flesh eating. The treatment is surgical debridement, followed by surgical debridement, followed by surgical debridement. You really need source control for this. You also give penicillin and IV clindamycin, and sometimes whenever the clindamycin is partly because with beta-lactams such as penicillin, you can have too much bacterial load. It overcomes some of the penicillin that's present. Clindamycin doesn't have that detriment, and so it doesn't matter how much bacterial load is present. Clindamycin will help take care of the group A strep. And then some, depending on the case, you can give IVIG. Okay, next question. Which of the following is or are true about group A strep infections? A, rheumatic fever occurs only from pharyngeal strains of group A strep. Post-strep GN can occur even with appropriate therapy. Post-strep GN can occur from skin or pharyngeal strains. The treatment of strep pharyngitis with penicillin prevents rheumatic fever, or E, all of the above. Yeah, fantastic. Yeah, all of the above. So all those things are true. Rheumatic fever occurs only from pharyngeal strains, not from superficial or skin strains, but you get GN from either one, skin or pharyngeal. All right, that was group A strep. Now we go to group B strep. Again, we're still in the gram-positive cocci. So again, these are big categories. And part of the reason we want to do this is you understand the different types of bacteria, and then we go to common syndromes later on. So group B strep, major cause of newborn sepsis, bacteremia, pneumonia, and meningitis. It can cause UTIs in pregnant women, as well as postpartum endometritis and bacteremia. Early onset group B strep, usually up to 7 days of life. So usually it's very quickly after delivery. Mom typically has obstetrical OB complications. The kids tend to be premature, and the most common manifestation is sepsis, followed by pneumonia. Those are the two most common. Most commonly sepsis, followed by pneumonia. Meningitis, far less, a percent of the time, and the case fatality is anywhere between 5 and 15%. So there's early onset, late onset, 7 days to 89 days. That's late onset GBS. Median is usually about a month of life. The most common manifestation is bacteremia without a focus. So kid comes in with fever, you get a blood culture, group B strep. That's it. Meningitis happens more commonly in late onset than early onset. Other manifestations include osteomyelitis or septic arthritis. You can also get adenitis and cellulitis. Serotype 3 causes most of the late onset, and the case fatality rate is far lower. Preventative therapy to mom for group B strep has dramatically positively impacted early onset disease, but it hasn't really done much for late onset disease. And then there's late onset. These babies typically are premature and have a history of IV lines, and again, they typically show up with bacteremia without a focus. Fortunately, their case fatality rate is far lower than the prior. We diagnose this via blood cultures. There's antigen detection systems that are available in certain institutions. They're okay, they're not great. There's also now a lot of hospitals have PCR systems that can detect genetic material based on that fluid, and typically group B strep is included in that panel. The treatment is IV penicillin or AMP, plus gentamicin initially until you get sterile cultures. And then if it's pneumonia or sepsis, you do at least 10 days of penicillin. If it's CNS disease, you do 14 days. And then for septic arthritis, osteomyelitis, it's generally 3 to 4 weeks. And again, for most bone and joint infections, we usually do is 2 to 3 weeks. Bone infections, usually at least 3 to 4 weeks, if not longer. Generally in all staph group A strep infections. Group C and group G, similar to group A, cause pharyngitis, but they did not cause rheumatic fever. Rarely you can see them causing invasive disease such as bacteremia, pneumonia, osteoendocarditis. The treatment remains the same as for group A strep and for group B strep, penicillin. So group A strep, group B strep, group C, group G, treatment is penicillin. Enterococcus, again, formerly a group D strep. The main ones that cause disease in humans are Enterococcus faecalis and Enterococcus faecium. They can cause newborn infections, namely a UTI, polymicrobial abdominal infections, or bacteremia. Penicillin and ampicillin or vanc are mainly inhibitory. So while we typically think of vanc as cidal agent against things like staph for Enterococcus, it's not quite as effective. We typically add aminoglycosides such as gentamicin for synergy due to serious infections. It's important to check sensitivities. We tend not to have too many options to treat enterococcal infections. And so ideally, if you have something like faecalis, you can usually use ampicillin or penicillin. If you have something like faecium is the one that tends to be VRE, that you may have heard of in your hospitals, vanc-resistant enterococcus. Sometimes we'll use linezolid for that, or quinupristin, dalfapristin. And always, at any point, feel free to consult your friendly PEDS ID person We still need to work every now and then. Okay, next audience response. Which do you consider the most awesome pediatric specialty? Cardiology, GI, hospitalist, PICU, or ID? I couldn't put every subspecialty on there because, well, there's too many, and so I apologize. I was going to say I put the important ones, but then y'all might throw something at me for like the EM people in the room or something else. And to be fair, I do think hospitalist is a subspecialty, but my co-director, Dr. Roy, is a hospitalist, and so I have to like keep her humble every now and then. Yay, look at that. Y'all are so nice. Okay, so that was gram-positive cocci. We'll now go to gram-positive rods. So Listeria, Corynebacterium, Arcano, Bacillus, and Clostridium. And to be clear, when I say gram-positive rods, so like the Clostridium are anaerobes. So sometimes when I teach, I use them as anaerobes separately. But we'll consider them gram-positive rods for this. So Listeria. So the highest incidence is the newborn period, or if you're really, really old. Most colonized from mother. Usually they come from environmental sources such as sheep, goats, or poultry. You can have contaminated milk or soft cheeses. So I always ask if they buy their milk from, the store, or if they get it from a local farmer who lives near the border. One of the biggest outbreaks nationally was some cantaloupes in Colorado about 7 years ago, and then a few years later, the people who were responsible for that actually had charges brought against them, and they were found guilty, and they didn't clean the cantaloupes like they were supposed to. So lots of people got Listeria. Most recently, and probably nearest to my heart, was Bluebell ice cream. Had a Listeria outbreak a couple of years ago. We were in Texas, and so Bluebell's in Brenham, Texas. And as a consumer of Bluebell ice cream every single night when I'm at home, that was hard for me. I tell you. If you have a blood culture that shows diphtheroid organisms on a blood or CSF culture in a newborn, do not choose a contaminant. Chances are that's Listeria. The treatment is AMP or penicillin plus minus gent for synergy and severe infections. But mainly penicillin will treat this appropriately. TMP SMX is used for penicillin allergy patients. Corynebacterium. So again, most popular is diphtheria. Usually shows up as a URI, but then you get this gray-white pharyngeal membrane as seen here. This is the picture that's been historically used in most exams and talks. You get a low-grade fever, so again, there's that Celsius right there for you. Sometimes you get a myocarditis or polyneuritis. And the treatment is usually penicillin and antitoxin. Arcanobacterium. So this is always think of a teenager. You're not going to have a 2-year-old with Arcanobacterium hemolyticum. Think of it if they give you a 15-year-old with what looks like strep throat and scarlet fever, the answer is Arcanobacterium. And you can treat it with penicillin or a tetracycline, right? Because it's usually going to be a teenager, and they can take tetracyclines, okay. Bacillus anthracis, again, the most popular. So there's a cutaneous form of anthrax and a pulmonic form. Usually for the cutaneous, it's a painless papule that becomes an ulcer, a little black eschar, and you get non-pending induration and swelling around it. And so it looks pretty awful, and you would think it'd be super duper painful, but it's not. And the pneumonic form, obviously, on the x-ray. Bless you. Bioterrorism for anthrax, right? So we worry about that quite a bit. It's not spread person to person, unlike the plague, which is Yersinia pestis, or smallpox. Notice there's a widened mediastinum you typically sort of see in that x-ray, but they'll give you a better x-ray probably on the test. If they wanted you to know what widened mediastinum is bacillus. Skin lesions occur in ranchers, and the treatment is usually Cipro or Doxy. But then pen is also effective if you get sensitivities back. Bacillus cereus, probably learned in med school, right? 2 varieties. Both are usually self-limited and do not require therapy. The emetic type, which is the short one, so think about it short, right? So it only gets to esophagus, stomach, and you throw it all up. And that's usually due to the preformed heat-stable toxin that you typically think of with fried rice, left at room temperature. And then the longer incubation has to go lower down into your intestinal tract, so then you get the diarrhea, 8 to 16 hours after ingestion, and that's due to enterotoxin produced. in the GI tract. Every now and then you'll see Bacillus cereus causing injuries to the eye or infection of the eye. This is usually due to a penetrating injury. Bacillus cereus and other Bacillus species can also cause IV catheter infections, namely in your oncologic patients. And so if you have an immunocompromised kid who has a line and they grow gram-positive rods, you consider a Corynebacterium, which is possible, or a Bacillus species. And you need vancomycin for that. Clostridium, so C. diff, we'll talk about it a little bit later, is antibiotic-associated colitis. Botulism, right, is also due to Clostridium, where it blocks presynaptic acetylcholine release. Think about it in the honeys that are given to babies. Clostridium perfringens is usually pretty bad food poisoning that looks like the diarrheal type of bacillus. Septicum is also associated with the GI malignancy, so think about that correlation, and it's really the main thing they'll ask about. And gas gangrene on exam is usually septicum, perfringens, tetany, or will be the options. And then the alpha toxin is what causes the main immune response to all of these clostridial infections. They're usually not going to ask you to distinguish between those, but know that they all do a little bit of different clinical manifestation or association. Okay, next audience response. 12-year-old female steps on a dirty nail with cow feces on it. And of course, her dog licks the foot after the injury. She's had 4 tetanus immunizations in the past, and her last immunization was 6 years ago. Which of the following, if any, does she require? Tdap only, DTaP only, Tdap and tetanus immune globulin, DTaP and tetanus immune globulin, or nothing at this time? All right, Tdap only. All right. So and then some said Tdap plus immunoglobulin. Okay, right. So this is it's right. So it's Tdap only, and we'll get into why. Right. So people remember this different ways. There are different ways to do it. So this is how I sort of do it. So, right. If the wound is dirty, and they have less than 3 vaccines, or you don't know what they have, they get vaccine and they get immune globulin. If it's dirty, but their immunizations are up to date, namely if they had their most recent one in less than 5 years, they don't need anything. If it's dirty and they've had at least 3 and the most recent one is less than 5 years, or the most recent one is more than 5 years, you give Tdap. Or if they're 7 or up, or you give DTaP if they're less than 7. Right? So if it's dirty, you probably need to give at least the vaccine. And if it's been more than 5 years since their vaccine, then you need to give. Sorry, if it's dirty, right? Think about it that you need to give the vaccine definitely, unless they're up to date. If the wound is clean and the immunizations are up to date, mainly less than 10 years, then you don't need to do anything. If the last immunization was more than 10 years ago, then you give either Tdap or DTaP. And a lot of times, you can create like a 2x2 table. And what I did was I memorized that and then kept writing it down over and over again. And then when I sat down on my exam, I wrote it out again so I didn't have to think about it. That's how I remember it. So tetanus, this is sort of the epistotonic posture that you can typically see with tetanus. Okay, that was gram-positive. So now we're going to go to gram-negatives, which tend to be a larger group. So this is fun. This is exciting. All right, gram-negative cocci, right? Far fewer than gram-negative rods. So Neisseria and Moraxella. Next question. 18-year-old male college freshman presents with Neisseria meningitis. He lives with his pregnant girlfriend who works part-time in a daycare. I know, right? Can you believe that? You see him in the emergency department and examine him for 30 minutes in a closed room. A nurse checks him in and holds his hand while he takes his vitals. That is very nice. He must have come to the pediatric ER. Sorry. Who should receive prophylaxis? Nobody? Only the girlfriend? The girlfriend and you? The girlfriend, you, and the nurse? The girlfriend, you, the nurse, and the entire daycare? Bless you. Ooh, only the girlfriend. Oh, that's great. Y'all did a fantastic job. Yeah, so only the girlfriend should receive prophylaxis for Neisseria, and we'll get into that. So Neisseria meningitis is a normal inhabit of our throat. We typically see issues whenever someone has a complement deficiency. So if you have recurrent Neisseria infections, think of terminal complement deficiency, C5 through C9. The presentation typically is someone who's very ill, fever, hypotension, diffuse purpuric lesions of petechiae. Typically they're in DIC as well. The treatment is penicillin. So old school penicillin will take care of Neisseria meningitis. You prophylax all household contacts, that's the girlfriend. Daycare, if you have a case in the daycare, significant others, i.e. girlfriend. Healthcare workers with intimate oral contact. So if they had to intubate this person or perform mouth-to-mouth, those people should receive prophylaxis, not someone who checked them in with vitals and not you who examined the person without doing an intubation or mouth-to-mouth resuscitation. And usually the prophylaxis is rifampin or Cipro, and then if they give you that the person who needs prophylaxis is pregnant, you give them ceftriaxone. So gonococcal ophthalmia, right? So another Neisseria and Neisseria gonorrhea. It's where newborns pass through the infected birth canal. It's prevented with eye ointments given at delivery. It usually presents 2 to 7 days after delivery with bloody, green, or serosanguinous eye discharge. What you want to do is take some of that discharge and do a gram stain. You don't do a culture, just do a gram stain to see if you see gram-negative diplococci. If you see gram-negative diplococci, then you do a septic workup because they have possibility of invasive disease at this age. And the treatment, if it's just eye disease, is 125 milligrams of ceftriaxone for 1 dose. If it's invasive disease, we usually do IV ceftriaxone. Whenever the drainage is less than 2 days for eye drainage, it's usually a chemical reaction. If it's 2 to 7 days, it's going to be gonorrhea. If it's after the first week of life, it's usually going to be chlamydia. It's sort of the timeline of goopy eyes in a baby. Bordetella pertussis. So pertussis has the highest incidence of disease at less than 12 months and the highest incidence of death at less than 2 months. The most common source of Bordetella is going to be mom, then dad, then siblings, and grandparents. Apnea is the most common presentation at less than 2 months, and those kids have the highest risk of mortality. So that's why we got to be really careful about those kids. The main way we diagnose pertussis now is do a PCR of a nasopharyngeal swab. The treatment is azithromycin. It's also the prophylaxis that we give. And again, any kid who's less than 2 months, some people say 4 months, you hospitalize those kids because of the risk of mortality. And then everybody gets Tdap because pertussis is much more communicable than others. Again, the 3 phases of pertussis, not on here, but just so they're right. So there's the catarrhal phase, there's the paroxysmal phase, and the convalescent phase. And you would think that the most contagious time would be the paroxysmal phase, where people are coughing, the paroxysmal cough and the whoop and whatnot. But it's actually the catarrhal phase, and this is where I'd usually ask residents to tell me why is the catarrhal phase the most contagious. Well, it's mainly because it looks like a cold. And nobody really cares that much if a kid has a cold. So they're around a lot of people, they have the highest bacterial burden, and they are less likely to have enough immune response to be protective, and so they can spread it very easily. Once you get the convalescent phase is when people start thinking of pertussis, the bacterial load is lower, you have immune system producing antibodies to it, and you usually give therapy at that point. And the only way to affect the person's course of how their pertussis is going to go is you give them therapy during the catarrhal phase. Again, where it looks like a cold. That's when you give it to them. It helps prevent some of the symptomatology or lessen the duration. It also is protective from a prophylactic standpoint. If you give it to them during the paroxysmal phase, it's not going to affect their course, but it helps prevent the spread of pertussis. Moraxella catarrhalis is the third most common cause of otitis media and sinusitis. It typically produces a beta-lactamase, so an enzyme that breaks down beta-lactams, but amoxicillin usually works for this. Other treatments include amoxiclav, erythromycin, and tetracyclines in second-generation cephalosporins. Okay, so the bigger group of gram-negatives are the gram-negative rods. Pseudomonas, right? So if you see a nail going through a shoe, think of Pseudomonas. See IV drug user, you think of Staph aureus, and you think of Pseudomonas. Diabetics will have a chronic otitis externa. Sometimes you'll see a round, indurated black lesion with a central ulceration. That's ecthyma gangrenosum, so sort of here. If you see that, think of pseudomonal bacteremia and the possibility of immune-compromised state, namely an oncologic process. And if you have a hot tub rash, that's typically due to Pseudomonas folliculitis. That typically is self-limited. Not that you should avoid hot tubs. They're fantastic, but they're usually self-limited. Typically don't need an ID doctor for those. So again, ecthyma gangrenosum, a consideration for oncologic process if you see this on exam. Burkholderia cepacia, it's formerly a Pseudomonas, but we decided to make it its own category. Typically we see it in immunocompromised kids, namely cystic fibrosis. If a cystic fibrosis patient has this, it portends a poor prognosis. It is typically difficult to treat and usually use meropenem, which is a very broad spectrum beta-lactam. Other options include ceftaz, TMP-SMX, and chloramphenicol. But again, most immunonormal patients are not going to have this. So if you see B. cepacia, think about a kid with cystic fibrosis. I don't have this pet. This is just a picture to kind of discuss this. If you see an iguana mentioned of the test, what is the correct answer? Shigella, Salmonella typhi, Salmonella non-typhi, E. coli 0157H7, or iguana dung soup. I don't actually know what that is. Okay, yeah, good. So Salmonella non-typhi, not Salmonella typhi, which is typhoid fever, right? So Salmonella typhi, typhoid fever, is contaminated food, milk, or water. It typically sees the gallbladder in adults who are the carriers. You can have rose spots on the trunk about a week into the febrile episode. Treatment tends to be TMP, SMX, or Cipro. There is a typhoid vaccine that you give to travelers only. There's an oral version that you give to kids 6 and up, and an inactivated injection that you give at 2 years of age and up, and it has a really good protection rate. That's typhoid fever, Salmonella typhi, and then Salmonella non-typhi gives you diarrhea and diarrhea. So it's usually when you have handling chicken, eggs, milk, or tomatoes and not cleaned properly, or you have iguanas, baby chicks, and turtles. Apparently people have these still as pets. I'm not going to ask for a show of hands of who has a turtle or iguana as a pet, but this is one way that infectious disease doctors stay in business, is for people to have these as pets, so thank you. Also, you can get it as a family get-together with grandma's homemade stuffing full of salmonella. The treatment is usually self-limited, so there's usually no need to treat. In the Red Book, which is one of our big books, it says, although of unproven benefit, kids less than 3 should be treated. We also treat patients who have sickle cell disease or immunocompromised state. TMP, SMX, Cipro, amoxicillin, or ceftriaxone. There's some resistance building to amoxicillin, so it's not always usually the first line of therapy. So again, iguana, salmonella, turtle, salmonella. Okay, next response question. If you could have a superpower, what would it be? Flying, laser beams from your eyes, or I guess you could have X-ray vision as well. I was talking to PICU nurses the other day, and we were talking about superpower, and they wanted X-ray vision for whatever reason. Invisibility, super strength, or being an ID doctor. All good options, I think. What will the audience say? I think there should be at least probably 9-ish E's. Flying, really? More than invisibility or laser beam? Super strength. You know, seen in was it Incredibles 2? That was pretty fun. I took my kids. My 4-year-old was scared of the bad person. Yeah, I know, right? 4-year-old scared. That's silly. I told her that too. So there's salmonella. Whenever you think of salmonella, always think of Shigella. So Shigella, you think of daycare exposure. Toddlers typically peaks in the summer, contaminated pools and lakes, and it's always spread person to person. So Shigella only takes a few organisms to spread, as opposed to Salmonella, which takes tens of thousands. The only way I remember that is Shigella spelled shorter, fewer letters to get Shigella and then Salmonella. So that's how I remember Shigella is easier to spread. For Shigella, you tend to have rectal prolapse and bandemia, and if you have seizure activity, think of Shigella if you have a GI infection. You always treat this as opposed to Salmonella, which is typically self-limited. Shigella, you always treat, you can either do PO Isethro, sometimes you can do TMP SMX depending on your local sensitivities. E. coli, for GI infections, the enterotoxigenic or ETEC is usually the traveler's diarrhea where you give Azithro or Cipro. For EHEC, enterohemorrhagic, 0157H7, that's the one that typically induces hemolytic uremic syndrome. That can come from unpasteurized milk, undercooked beef, where you have the triad of HUS of renal failure, thrombocytopenia, and hemolytic anemia. And you do not give antibiotics for this on your board exam. Supportive care. And one thing I think we'll mention later, E. coli, the most common cause of urinary tract infections in kids. So if you see a urinary tract infection, 90% of the time that's going to be E. coli. H. flu. We don't typically see as much H. flu anymore, which is good. It's a pleomorphic gram-negative coccobacillus. Again, used to be the most common cause of bacterial meningitis and bacteremia in kids. Now there are non-Hib strains that are encapsulated and then non-typable strains which are non-encapsulated. And they're responsible for conjunctivitis, otitis, sinusitis, bronchitis, newborn meningitis, and bacteremia. But again, it's far less common now that we have a vaccine for Hib. H. flu, meningitis, there are lots of complications. And again, pediatricians who practiced well before me saw this on a unfortunately, a very frequent basis. You'd have subdural empyema, brain infarcts, ventriculitis, and brain abscess. The most common sequelae of H. flu meningitis was hearing loss, and that's actually still the case for any sort of bacterial meningitis. The most common sequelae of bacterial meningitis is hearing loss. And so that's always one thing you want to look for whenever you have a kid you're treated for bacterial meningitis is hearing loss. For H. flu, you give steroids either before or at the time of administration of antibiotics to prevent hearing loss and other neurologic sequelae. H. flu is really the only bacteria we do this for on your exam. Clinically, we'll consider it, or some say do it for other bacterial meningitides, but for your board exam, the answer is just H. flu. We give steroids. Also, it can cause some buccal cellulitis as seen here. It's also a very common cause of epiglottitis, which again, we don't see very often anymore. Now it's usually Staph aureus as the cause of epiglottitis. But H. flu epiglottitis occurred in 2 to 7 years of age. They had the cherubate epiglottis seen here. This is the one where you don't want to try to use a tongue depressor. You always make sure they want to maintain an airway. They can have drooling and dysphagia. But then that's epiglottitis. So typically, if they want you to answer H. flu, they'll say this is an unvaccinated person. Otherwise, epiglottitis is going to be other etiologies like Staph aureus. H. flu bacteremia is not the same as pneumococcus, and the reason we put that there is for strep pneumobacteremia, there are some say you do not have to treat strep pneumobacteremia because it's somewhat self-limited, even though it's a bacteremia. For H. flu, that's not the case. You want to make sure you treat bacteremia due to H. flu. Treatment is usually with the third-generation cephalosporin, so either ceftriaxone or cefotaxime. If it's uncomplicated CNS disease, you want to treat 7 to 10 days. But septic arthritis, usually, again, 2 to 3 weeks. If it's osteo or endocarditis, 4 to 6 weeks. And then for otitis media, again, otitis media, causative agents are strep pneumo, MCAT, H. flu. We've already talked about are the most common causes for otitis media, and you try amoxicillin first, right? High dose amoxicillin to try to overcome any sort of beta-lactamase. If it's resistant, then you use amoxiclav or TMP SMX. If you're exposed to someone who has invasive H. flu disease, similar to Neisseria meningitidis, you want to give them prophylaxis, and namely that's rifampin. Again, if they can't take rifampin because they're pregnant, you want to give ceftriaxone. But H. flu and Neisseria meningitidis are the two you give prophylaxis for. Mycoplasma pneumoniae, sort of an atypical, is a frequent cause of URI and lower respiratory tract infection in kids. It's generally self-limited. A certain percent go on to develop a lower respiratory tract infection, namely walking pneumonia. 10% can develop erythema multiforme rash, usually maculopapular rash. It can invade the central nervous system, or it can have an effect on the central nervous system, and sometimes called cardiac disease, although those tend to be uncommon. It can be a cause of acute chest syndrome in kids who have sickle cell disease, and is associated with autoimmune diseases such as hemolytic anemia on occasion, and a Stevens-Johnson-like syndrome. Usually they're going to be school-age children or adolescents. There's no long-term immunity, and so just because you check serologies doesn't mean they've had it once before doesn't mean they're going to have lifelong protection. The diagnosis typically is usually a PCR for mycoplasma. Serology is okay, but serologists can stay positive for a very long time. So if you had mycoplasma in January and you test them now in August, they could still be positive because of their January infection. And we typically don't use cultures anymore because they're not very sensitive. Treatment typically reduces symptoms, spread, and recurrences, and we usually use macrolides. So usually azithromycin is the treatment we usually use right now. Treatment of URI and CNS disease does not alter the course of the illness. Okay, next audience response. Which is your favorite Chicago Cubs team? I don't know how many. Anybody here from Illinois area? I saw somebody with the Cubs blanket up there. All right, that's fantastic. So I'm not from Illinois. I'm from Louisiana, but I grew up watching the Cubs and big Cubs fan. So just curious as to your favorite Cubs team. I'm sure many of y'all are very good Cub fans. So which is your favorite Cubs team? From 1908 when they won the last World Series before 2016. 1989, right, where they had Mark Grace. 2003, where they have Bartman interfering with the foul ball. 2016, where recently won it, and I got to wear my Cubs jersey to work and to recruitment selections dinners. Or if you're a Cardinals fan, you can just go ahead and leave now. And don't worry, we're going to have a break soon, so don't freak out that we're going to just keep going. We'll have a break at some point. Come on, seriously? I know. I think I knew who that was. At least some of them. Anybody from? Are there Cardinals fans in here? Or are you just saying the Cubs suck? Any Cardinals fans? Thank you. I like it. Okay. Yeah. I'm going to Chicago tomorrow to go see them play the Nationals. I'm very excited about that. Yeah, I'm very excited. So thank you for being flexible with me being able to do today as opposed to tomorrow or Friday or Saturday. I have a game to go to. Okay, other gram-negatives. Yersinia pestis, also known as plague, right? So typically you're going to see this usually in the mountains, in the Rocky Mountains in the west, California, Colorado, Idaho. Fleas transmit this, and there are two types. There's bubonic. There's pulmonic, right? Bubonic is lymphadenopathy that separates, and then the pulmonic that tends to be very contagious and can spread person to person. We talked about as opposed to anthrax. Diagnosis is aspirating the lymph nodes, and the treatment tends to be streptomycin or chloramphenicol or doxy. Sometimes if streptomycin is hard to get, sometimes you can use gent. This is an example of what it looks like, the really large buboes. It can be used as a bioterrorism agent, with pneumonia being the biggest concern. It usually presents with a young person with hemorrhagic pneumonia and high fever, and is contagious to others. Yersinia enterocolitica. So if you have usually a teenager that has what looks like appendicitis, but it's not really appendicitis, consider Yersinia enterocolitica or pseudotuberculosis as a cause for this pseudoappendicitis syndrome. It can cause bacteremia in those with sickle cell disease and diarrheal disease in infants cared for by infected caregivers who handle chitterlings. You might know what chitterlings are? Chicago. Same as chitlins, right? So usually the Yankee people talk about chitterlings, and very, very professional. And us in the South, I'm from Louisiana, so it's chitlins and whatnot. So it's pig intestine, right? So it's for some reason people don't like pig intestine. That's just the weirdest thing to me. So anyway, if you handle chitlins, you can get Yersinia enterocolitica, and we'll talk about other things you can get from chitlins as well. Yet we still like it in the South. Legionella. So typically this is called a multisystem disease. Mainly it's going to cause pneumonia that looks very similar to mycoplasma. Every now and then it can cause CNS disease with some delirium and confusion. Azithromycin is the drug of choice. Sometimes you could do serology to diagnose it or do a urine Legionella antigen to identify Legionella. Klebsiella, usually Klebsiella pneumoniae is a cause of bacteremia, pneumonia, UTIs, and meningitis. Commonly, you'll see it as UTIs in kids. You tend to have to use a cephalosporin because it tends to be resistant to ampicillin because of the beta-lactamase they produce. Francisella tularensis. So this is where you think of rabbits, deers, and ticks. There can be ulcer glandular disease and others that we'll talk about. You usually diagnose it via serology, and you treat, bless you, with streptomycin or gentamicin. This is where you're going to see tularemia. So it's usually going to be Missouri, Arkansas, Kansas, and Oklahoma. That's typically where it's going to, and usually if they want you to answer tularemia, they're usually going to give you a location. So this is a happy little kid where you can see on his left lower neck, he has a little red spot, and you get a little closer look. That's sort of the ulcer glandular disease that typically occurs with tularemia. And then you can also get an oculoglandular syndrome that this gentleman has as well. Bartonella, so cat scratch disease. Typically, you're going to have regional adenopathy, and sometimes you can show up as a fever of unknown origin. Usually, it's a self-limited disease. Every now and then, it can cause CNS disease as well. While the diagnosis can be clinical, sometimes it's hard, so we typically use serologies, looking for IgG and IgG for Bartonella. And most time it's self-limited, but every now and then we'll use azithromycin to sometimes treat, especially if it's invasive disease like hepatosplenic disease or CNS disease, we'll use azithromycin or TMP-SMX. And there's a little fella with a regional adenopathy due to Bartonella. Again, it's not overly impressive, not warm red. The node itself isn't infected with like staph or strep, but it causes adenopathy there. Another gram-negative question. So, right, a neonate with fever grows Citrobacter in the blood. And that's all you know. You order a spinal tap and which other test? Abdominal ultrasound, CT of the head. Nothing but the spinal tap is necessary. Serology for a fungal infection or a ceruloplasmin. Okay, B, CT of the head, right? So Citrobacter and Enterobacter sakazaki, if you see those on your boards, brain abscess. Gram-negative meningitis can cause brain abscess, but these two particular bugs are the ones that they're going to put on the board to look for brain abscess. Citrobacter and Enterobacter. Other gram-negatives we're going to talk about briefly. No, I think that's it. So we talked about everything except for one. Another question. A 3-year-old male with low-grade fever and refusal to walk. No chronic illness, fully vaccinated, has 3 older sibs, and attends daycare. His vitals are stable, but he's febrile. On exam, his left knee is mildly swollen and has a reduced range of motion on flexion and extension due to pain. We suspect he has arthritis. Which drug should be used for empiric therapy? None. Wait for the culture to grow. AMP, ceftriaxone, Vanc or NAF alone, or ceftriaxone plus vancomycin. Okay, right, so most did ceftriaxone plus vancomycin. So this is where I would then ask my residents, well, why did you choose ceftriaxone plus vancomycin, even when we just said for most skin, soft tissue, bone, joint infections, we said staph, group A strep are the most common reasons, right? So in certain situations, we have Kingella kingi, right? So it used to not be that big of a deal, but then we've learned that it lives in the oral cavities of a lot of kids, and every now and then it can cause osteoarticular infections in toddlers, usually kids less than 4 or 5 years of age. And it typically doesn't look like staph. Usually these kids will come in who have had sort of a week of refusing to bear weight on a leg, but not really that sick, still eating pretty well, fever maybe to 101, and you check inflammatory markers and they're a little elevated but not exciting, but it's going on for between 5 to 10 days, whereas staph and group A strep, typically you're going to get them within 48 hours of refuse to walk, high fever, feels like crud, and their knee or leg or arm is terribly swollen and red. If it's the more indolent thing, it's usually going to be Kingella in kids less than 5. It's occasionally isolated in a culture, but it's very hard to grow, so now we have a Kingella PCR that we can do. And so that's the reason you would do ceftriaxone initially, in addition to vancomycin. You wouldn't do ceftriaxone by itself because, again, staph and group A strep are big causes of it as well. So these are acute doxycycline deficiency states. So if you have a kid with rickettsial disease, they need doxycycline. Those are rickettsia, and Ehrlichia and anaplasmosis. Other atypicals include AFB, so Mycobacterium tuberculosis and non-tuberculous Mycobacterium, actinomyces, and then some other pneumonias we'll talk about. So Rocky Mountain spotted fever, right? So rash, fever, arthralgias, they typically have a tick exposure. The rash will usually start on the distal palms and soles. Usually starts as a maculopapular rash and turns to petechiae. Sometimes they'll have a leukopenia, sometimes they'll have a hyponatremia. We usually do serologies. Sometimes we can do a biopsy of a particular lesion, but that's usually done far less often now that we have serology testing that can be performed. And again, treatment is doxycycline. So the distribution of Rocky Mountain spotted fever is not really in the Rocky Mountains, as you probably know. So really centralized in kind of the middle part and eastern coast, right? So Kentucky, Tennessee, Illinois, Missouri, Arkansas, North Carolina. That's where it's going to be. They'll usually give you a hint of kind of where they are because Rocky Mountain spotted fever can look like other diseases, including Ehrlichia and anaplasmosis. So this is sort of a person with sort of a resolving macular papular going to petechial lesions on the hand, suggestive of Rocky Mountain spotted fever. Q fever, also known as due to Coxiella burnetii. Again, this is a disease that is very uncommon, and yet the boards the boards may ask you about it, even though it is extremely uncommon. You want to think of goats, sheep, cattle, dairy herds, and usually you want to think of some sort of exposure to delivery of cattle or horses. You're going to have exposure to some sort of pregnancy materials of those animals that develop into Q fever. Again, somewhat nonspecific findings: fever, chills, myalgias, and the pneumonia on X-ray can appear anywhere between 4 to 97% of patients, so small range. So usually Coxiella can survive in meat hung in cold storage for over a month, or in dried wool or tick feces for over a year. And so usually it's people who have exposure to those types of materials that tend to get Q fever. Again, serologic testing is the way to diagnose it. Most resolve without treatment, but again, when in doubt, give them doxycycline. Ehrlichia and anaplasmosis, these are tick-borne illnesses. So when you think of the South, Southeast, Midwest, that's going to be Ehrlichia. If you're going to be in the North or California, it's anaplasmosis. So they're similar, very similar diseases, but one's in the South, one's in the North. Ehrlichia is in the South, flu-like illness with pancytopenia, plus minus rash. Usually do serologies, and you treat them with doxycycline. Anaplasmosis, the only difference is that the infections live in the neutrophils, not the macrophages. And again, epidemiology-wise, you're going to need to know whether or not it's in the North or the South. Ehrlichia in the South, anaplasmosis in the North in California. Mycobacterial disease and acid-fast organisms, so non-tuberculous Mycobacterium, also known as atypical Mycobacterium, tuberculosis, and nocardia. So non-tuberculous Mycobacterium. So Scrofulaceum and Mycobacterium avium intracellular complex. So again, this is going to be your adenitis, your cervical lymphadenitis. And so this is going to be usually kids who come in with an enlarged lymph node, Pediatrician gave them a mox, or maybe they give them a mox clav, or maybe they give them Clinda thinking it's like a staph or group A strep infection. Doesn't really do anything, but it kind of hangs out over the next 3 or 4 weeks. Try something else, try TMP-SMX. Doesn't really do anything. Start turning purple or violaceous. So we're now 6 to 7 weeks into it, and it's just kind of hanging out there. That's non-tuberculous mycobacterium. And that's either due to avium intracellular, Scrofulicium, abscessus, but it's a non-tuberculous mycobacterium. And to diagnose that, you excise the node. To treat it, you excise the node. So excision is both diagnostic and curative. Every so often, if you get a lot of liquefaction in the area where the node was, or the surgeon didn't feel comfortable that they got all of the infection out, we'll use adjunctive antibiotics, namely usually clarithromycin plus rifampin. But again, it's for your board exam. The surgeons typically get everything out on your board exam, so they're very good. Then Mycobacterium leprae or leprosy. You need to make sure you get a good exposure and travel history of where they've been. Most of the cases now come from California. You do acid-fascinating of skin or the nerves. Typically, you do it earlobe. We see it far, far less now than we used to. And then Mycobacterium marinum, that typically give you someone who's been cleaning fish tanks, where you get skin ulcerations and lesions along the lymphatic tracts. So think about this one. Along with sporotrichosis, but they'll tell you that the sporotrichosis person, which we'll talk about in a little bit, is someone who's a gardener, got it, doing gardening stuff. This person got the same symptoms, basically, except they were cleaning out fish tanks. MTB, so Mycobacterium tuberculosis. Children get TB from adults. They usually don't get it from other children because they cannot spread the AFB very well, so they usually get it from adults. So whenever you have a kid in the hospital who has pulmonary TB, you put them on isolation, you worry less about the kid giving it to everybody that is taking care of the kid. You're more worried about the adults who take care of the kid at home who have TB, who gave it to the kid, then spreading TB to everybody in the hospital. So it's hard to get TB from a young kid. Infants and adolescents are more likely to be symptomatic. Primary TB infection usually results in a latent TB infection, where you sort of have germs in your body but not terribly active, and that can eventually lead to active disease, but most do not have active pulmonary disease with their initial infection. Pulmonary disease occurring within the primary initial infection is more common in adolescents. It's more common in HIV-infected patients and will show up as a lower lobe disease process. If it occurs months to years after the initial infection, that's typically where you have the upper and apical lobes being affected. Pleural effusions can sometimes be seen with pulmonary TB, although they're fairly rare. A pleural biopsy will increase the yield of recovering AFB. Pericardial effusion, again, much less common. Sometimes on the exam you'll hear distant heart sounds, which isn't necessarily terribly specific for TB, but usually it'll give you an epi history to suggest somebody has TB. And then you do a pericardial biopsy, will have a higher yield. Most of the time that's not terribly necessary because you usually can make the diagnosis of TB otherwise. Meningitis, so usually this is another form of TB that's very invasive, so typically they're going to have pulmonary TB and then it invades further into the central nervous system. Kids less than 2 years of age, if they have pulmonary TB, you should do a spinal tap. Even if they don't have evidence truly of any sort of central nervous system disease process, you do a spinal tap because the likelihood of those kids having invasive disease into the central nervous system is high. Again, most common 6 months to 2 years of age, 4 years of age. SIADH is common. On the MRI, you're looking for basal ganglia enhancement. Tuberculomas inside the brain on imaging are pretty rare in the United States, so we typically don't see those in kids. And sometimes those can get worse after initial therapy and then get better later on. TB in adolescents, they'll typically have the fever, night sweats, weight loss. They tend to be very contagious. Again, younger kids usually less than 10, not terribly contagious. Older kids, because they can now produce enough force to spread the AFB into the environment. Sometimes they have hemoptysis, and then upper lobe infiltrates with hyaloadenopathy. You'll typically see with adolescents. So how do you diagnose it? So there's skin testing, right? So there's PPD or the TST. Remember, reading is based on induration, not redness. One of my mentors in fellowships taught me to place a PPD, and then also read it with your eyes closed, right? Because if you read it with your eyes open, you might be biased with the redness and say, oh, they have 10 millimeters of induration, when really they have 2 millimeters of induration with 10 millimeters of erythema. So always remember that it's induration for the PPD and not erythema. And also you need to know what's positive for PPD, right? So there's 5, 10, and 15. If you have immune system dysfunction or HIV, if you have a organ transplant recipient, again, you're going to be immunocompromised based on the therapy you get, or you're receiving a large dose of prednisone, or you have close contact with somebody who has known TB, your positive reaction is 5 millimeters of induration. 10 millimeters becomes positive if you're homeless, if you're an IV drug abuser, you're a healthcare worker, so most of everybody here, if you're a kid less than 4 years of age, or on a lower dose of steroids for a long time. That's 10 millimeters. Everybody else, 15 millimeters. So know most of what happens with 5, 10 versus 15. PPD is not terribly reliable in kids less than 6 months of age. And remember that the idea of skin testing is that the skin test has antigens, you're relying on antibody response. If you just got infected with TB, you might take you a little while for that antibody response to develop and produce a positive PPD. So you do a skin test, it's negative, you want to repeat it in about 8 to 12 weeks to make sure that the test remains negative. We now have a blood test that we can do for TB, and this is great. We don't have to rely on anybody coming back. It's a blood test that looks at the interferon gamma release from T lymphocytes that are in response to antigens that are specific for TB. So one of the problems with the skin test is that it has a lot of antigens, and you can produce antibody response or induration because of your response to non-tuberculous mycobacterium, any of the ones we talked about. With the IGRA, either the T-spot or the quantiferin gold, they look at very specific antigens related to TB. So a positive test with an IGRA, that means it's responding to TB. A positive test from a PPD, it could be TB, but there's also a decent chance it cannot be TB. So the blood test is much, much, much more specific for TB. It cannot distinguish between latent infection or active disease. All it tells you is antibody response. It's good because it can be used in kids 5 and up, and that's what you would need to answer on the test. Clinically, every now and then we'll use it on kids less than 5, but that's not for your test, and it's really depending on different clinical scenarios. Again, if the IGRA is positive, it's TB. If the IGRA is negative, it doesn't mean you don't have TB. It's not any more sensitive than the PPD, but it's much more specific. So a positive IGRA means TB. It's also helpful in kids who have received a BCG vaccine because there's no cross-reaction. Okay, so a question about mycobacterium. If a PPD is 16 millimeters in a 12-year-old girl with a history of TB exposure and has a productive cough, what do? You start INH for 9 months, you just hang out, you do a chest x-ray, do a sputum times 3. If those are both negative, you start INH for 9 months. You do a chest x-ray, sputum times 3. If either is positive, you start INH for 9 months. Repeat PPD in 2 weeks to be sure that it's not a false positive. Ooh, okay. So start ANH for 9. So some thought start ANH for 9 months. Some said check X-ray, if both negative. Okay, and we'll get into this. Okay, if you diagnose active TB disease, how do you initially treat it? INH and rifampin, unless the resistance is more than 0.5%. INH, rifampin, pyrazinamide, plus minus ethambutol or streptomycin. INH only. INH, rifampin, and ethambutol. I don't. I call the state health department to investigate this. Okay, yeah. Now, we laugh about the health department, but they're actually very helpful. Most are very helpful. right? Because the idea is that they then have to investigate kind of where the source for this kid who got TB, where did it come from? So the idea for the first question, so when you have somebody, that kid was 12, right, and had a 16 millimeter PPD. So regardless of the exposure history, that was a positive PPD, right? So then if it were a 6 millimeter PPD, then that was still positive in her because she had exposure to somebody with TB. And so with that, you have a positive PPD, you want to check to see if they have active disease or if they have latent disease, right? So that's where you do a chest x-ray, and you do sputums times 3 to look for AFB. If those are okay, then you say this person has latent TB, and you treat them with 9 months of INH. If either of those, if the chest x-ray is positive or the sputums are positive, you then start therapy for TB, which we just talked about. INH, rifampin, pyrazinamide, plus minus ethambutol or streptomycin. The reason it's plus minus ethambutol or streptomycin is because based on what you know, if the adult that gave it to them, if you know who that is and you've grown TB from that person and you have sensitivities and it's sensitive to INH and rifampin, you don't need ethambutol. If you don't know who the person who gave it to him is or don't have a culture back or it's resistant, you do INH, rifampin, pyrazinamide, and ethambutol. And then once you get sensitivities back, you can pare that down. But you don't need to know that for exam, just what you initially start them on. INH, rifampin, pyrazinamide are hepatotoxic, so when you have somebody on TB therapy, whenever you have somebody on TB active disease therapy, you check LFTs on a frequent basis. The lab testing is indicated when toxicity develops mainly in latent TB. So when you give a latent TB diagnosis, right, so they're positive PPD or positive IGRA, but they're asymptomatic, their chest x-ray is normal, their sputums are negative, so you're telling them INH for 9 months, those kids don't need frequent lab testing. Ethambutol is not hepatotoxic, but can cause a decrease in visual acuity. Usually decreased color perception is the first indication. And the streptomycin can cause oto and nephrotoxicity in adults, likely in kids as well, right, because it's an aminoglycoside. Nocardia. So typically this is a skin disease in kids who are immunocompetent. For immunocompromised kids, namely CGD, HIV or organ transplant, they can have a cavitary pulmonary disease, CNS disease, or a deep tissue abscess. Usually you're going to grow this on a blood culture or blood or chocolate agar on 3 to 5 days, depending on the source you get. And the treatment is usually TMP SMX if you have a mild cutaneous disease, or if it's more invasive, such as cavitary disease or CNS disease, you're going to use usually meropenem plus minus amikacin for that. Actinomyces is a gram-positive rod. This is also an anaerobic infection. We don't typically see it very often, but usually the story you'll get is a kid who had recent dental work, and they developed an abscess, usually around the jaw or mandible, that continues to drain despite being IND'd by the surgeon. Then you do a culture. Sometimes they'll show sulfur granules on it, but then they'll also grow on culture. Usually treatment is penicillin. Usually treatment is penicillin for IV penicillin for a few weeks, and you go to oral penicillin for between 9 to 18 months. And this is a kid we had in clinic who had cervical facial disease from a dental source. Chlamydophila. So mainly it's pneumonia. You typically see that in adolescents, typically just similar to mycoplasma pneumonia you'll see in adolescents. It's usually community acquired. It is person-to-person spread, but the treatment is macrolide, right? So azithromycin, clarithromycin. Psittacosis, this is what you think of with birds, especially poultry, and it's not just parakeets or macaques, it's other birds as well, so it's really a ornithosis, I think. This is an intracellular parasitic bacteria. Again, pretty unusual, but more likely they're going to give you someone who exposed to birds or is a pet store owner that would have this. They wouldn't just give you a random kid with psittacosis. And again, a lot of things, what you'll see in infectious disease, they should give you epi clues, because sometimes a lot of these illnesses have disease processes that show in very similar ways. So sometimes they have to give you some epi history. Humans acquire infections by inhalation or handling sick birds. Every now and then there are some reports of infected poultry, but not usually. Pneumonia and splenomegaly exist, and then you could typically have really high fever. We typically do serology testing for this. Sometimes there is some cross-reaction with Chlamydophila pneumoniae, but now we could do a PCR on occasion, but that's usually not what you need to know for your boards. The treatment is tetracycline. Chlamydia trachomatis. So this is one of the things that can cause eye disease in kids. This is the one that happens between 7 to 14 days when you have your eye goop as a baby. Newborns get it from their moms as they travel through the birth canal. Eye drops do not prevent this infection as they do for gonorrhea. Sometimes they can get the pneumonia, and usually in the first 3 to 4 months of life, they'll usually have that persistent staccato cough, and sometimes they'll have some eosinophilia as well. The treatment is oral azithromycin. Another audience response. If you were stranded on a deserted island, but you could have one antibiotic, which would you choose? Vancomycin, linezolid, levofloxacin, TMP-SMX, or rifampin? And this is, I don't think there's really a right answer, but I was asked this a year or two ago by one of our current chief residents. I thought it was an interesting question. Okay, so most people said linezolid. So you're only worried about gram-positive infections, huh? Some said levo, TMP-SMX. Yeah, the problem with vancomycin, right? So you have to give yourself an IV to get vancomycin, right? If you give PO vancomycin, which is great for C. diff, we'll talk about that. Has anybody tasted PO vancomycin? Right? It is awful. Like, it dries your mouth out. It makes you drool. It dries your mouth out, and then when you try to talk, you drool a lot. It is not very pretty. But the nice thing about PO vancomycin, it doesn't get systemic absorption, so it's great for C. diff. You don't have to worry about vanc levels or anything like that. But again, vanc, gram-positives only. Linezolid is good, gram-positives only, but it's available IV and PO. It has really good bioavailability, so linezolid is a good option, but again, only gram-positives. Levo, that's a great option, right? So it's IV and PO and has great bioavailability. And then it has really good gram-negative coverage, really good really good atypical coverage as well. So that's always a good choice too. TMP-SMX, that's okay choice. Rifampin, oh good, nobody chose rifampin, yeah. So remember, whenever you give rifampin, this is clinically speaking, make sure you tell the parents that it can turn their secretions red or orange, right? So urine, sweat, tears, poop. Parents really freak out when they see that and aren't expecting it. So anyway, okay. I think I would have chose levo. I don't know if there's a right answer. It will not be on the board exam, promise. Okay, spirochetes. So leptospirosis is a spirochete. This is probably very, very underreported. It's usually when skin or mucous membranes come into direct or indirect contact with a contaminated urine of an infected animal. So if you're walking around barefoot outside and you walk on cat pee or dog pee, that's probably one way to get it. Rats, dogs, livestock, wild animals also exist. Again, there are only 150 cases per year in the United States, but that's probably underreported. We typically don't think about it very often. It penetrates the mucous membranes and incubates for a little over a week and can spread to all parts of the body, so you can have really bad ischemic damage to renal tubules, liver, meninges, and muscle. There can be hepatocellular dysfunction and cause jaundice, and you can also have uveitis, conjunctival suffusion, like that, so really bad, really impressive conjunctival involvement. There's sort of two phases. There's the septicemic phase, which happens less than a week. It looks like a mild flu, but this is where you can have positive blood and CSF cultures for the organism. And then later on is the immune phase, where you have positive urine cultures, but negative blood cultures. So be aware of what diagnostic tech you want to do depends on the duration of their symptomatology. Usually it's contact with an infected animal. It can be anywhere between mild to severe disease. And remember the biphasic disease presentation of early disease, blood culture positive, late disease, urine cultures positive. And then treat with either penicillin or doxycycline. Lyme disease. So Lyme disease is a tick-borne spirochete, mainly in southern New England, mid-Atlantic, upper Midwest. That's where you're going to see it. So if they give you a kid in lower West Texas that's probably not going to be Lyme disease. Kind of shows up as three ways. There's early localized, where you have erythema migrans at the tick site, so usually the bullseye appearance at the tick site. Early disseminated, where you have multiple erythema migrans. 20% of the diagnoses typically happen several weeks after the tick bite. And then you have systemic symptoms, so myalgia, arthralgia, fatigue, fever. Typically, you get arthralgia in that early disseminated. You get arthritis in the late disease. You can also get CNS manifestations with palsies and aseptic meningitis in early disseminated. And then late disease, where you typically have large joint arthritis and peripheral neuropathies. Treatment of early disease prevents late disease manifestations. If you have the rash and you live in an area that's endemic to Lyme, you don't really need anything else. You call it Lyme disease and you move on and treat it with doxycycline. Otherwise, you require some serologies. So you do sort of the EIA first, and if that's positive, you then do a Western blot, where if you have positive bands, then that's considered diagnostic and you treat for Lyme disease. For early localized disease, so remember mainly the erythema migrans, you do doxy for kids who are 8 and above and a mox for kids less than 8. If they're early disseminated or late disease, you typically just go longer with therapy. If CNS disease is involved, you use ceftriaxone because of the penetration of the blood-brain barrier that ceftriaxone can get versus doxycycline. So we'll talk about a few different types of fungal infections. Candida species, most commonly Candida albicans, right? So normal host, commonly caused a thrush, commonly caused diaperdermatitis. Immunocompromised host is a common cause of thrush and diaperdermatitis, but it could also cause chronic mucocutaneous candidiasis, which, if you see it on your exam, is a really awful-looking disease. And and then you can get systemic candidiasis. Typically, that's going to be someone who has a central venous line or is immunocompromised. Usually, a normal immunocompetent kid is not going to have disseminated fungal disease. Again, diaperdermatitis. Thrush, right? So white curd-like plaques on the tongue, gums, or buccal mucosa. And then removal of the membrane reveals a red base, and usually give nystatin for that, which looks like on a slide. Okay, so there's a game that we play, right? It's called I've Never, right? I don't know if anybody's played it. So it's where the person says, I've never X, whatever it is, and if anybody in the room or playing has done that, takes a shot of espresso, let's say. And so we're going to do that just to sort of break things up a little bit, right? So usually the person saying it, it's true, and I think everything I have on here it is true about me. So the answer is, the answer A, shot, if you've done these things, i.e. been on a cruise, your answer would be A. If you've never been on a cruise, the answer would be B. And so, I've never been on a cruise. No shot, okay. Okay. It's kind of funny that even though they're 2% apart, B looks really higher than A. That's weird. Okay, so let's make that relevant to the study. So if you see a cruise on the test, what do you think about? Y'all. Are they allowed to answer? They're allowed to answer. Okay, so yeah, norovirus or Norwalk, right? So if you cruise, everybody comes off the cruise throwing up, diarrhea, Norwalk, norovirus. Okay, nothing to do with Candida species. That's just a digression that my residents made me do. Okay, Candida species. So there are many things that predispose you to Candida infection. So infancy, exposure to multiple antibiotics, pregnancy, if you're on steroids a lot, nutrition, prolonged anemia, burns, trauma, if you have diabetes, other endocrine disorders, malignancy, IV catheters, and immunodeficiencies. If you're an oncologic patient and have a severe immune deficiency, presence of a central line, presence of a bladder catheter, exposure to at least 2 antibiotics, or if one of those antibiotics is a very broad spectrum like meropenem, azotemia, if you are being taken care of at a tertiary hospital, so the chance of getting a iatrogenic infection, diarrhea, and you can also see candidiarrhea quite a bit. So some cutaneous manifestations of disseminated Candida infection. Coccidiomycoses, so you may have learned in med school about cocking your gun, right? So in the south, in the west, where saloons and whatnot. So that's the clue they're going to give you. They're going to be someone in the southwest or someone who traveled to the southwest. They usually inhale the fungus. Usually, pulmonary infection is often asymptomatic or self-limited. Cutaneous disease can manifest as lymphadenitis. In infants, if they get this and it's disseminated, sometimes they can have CNS disease that produces a very high mortality. The diagnosis is usually culture, but also you could do serologies as well. The treatment is fluconazole or itraconazole for a number of months. If they're severe disease, they need amphotericin B. And usually the liposomal form for older kids tends to work okay. If it's newborns, infants, sometimes they can tolerate the old school deoxycholate. Aspergillus, another fungus, right? So this is angio-invasive disease in immunocompromised patients. So typically, immunocompromised kid with lung disease, you want to think of aspergillus. So it can cause lung disease, CNS disease, cutaneous disease. Aspergillus can also cause allergic bronchopulmonary aspergillosis, or ABPA, which is a hypersensitivity reaction, where you can have eosinophilia and mucus plugging with decent amount of wheezing. Chronic sinusitis can happen with allergic sinusitis due to aspergillus, and you can also have aspergillomas, which are non-allergic, and then otomycoses, which can happen in otherwise normal kids. We'll see that in kids who have chronic ear drainage, and you do a fungal culture and it grows aspergillus. So that's how you diagnose it. You get it from culture. There's also a way to do a serum galactomannan, which is also known as aspergillus antigen. Looking for the cell wall components of aspergillus that might be present in the blood. Treatment is voriconazole. Aspergillus, voriconazole. Aspergillus, voriconazole. If they can't tolerate voriconazole, sometimes we could do amphotericin B. And if they still have disease after appropriate therapy, sometimes you need to have surgical intervention, especially for lungs, sinus, or cutaneous disease. Tinea pedis, also known as athlete's foot. So it's uncommon in young children, but very common in pre-adolescent males and adolescent males, usually a fourth or fifth toe. There could be severe tenderness, itching, and a foul odor, so you want them to avoid occlusive footwear to allow air to get to it. Dry the toes after bathing. You can use an antifungal powder that's absorbent. You can also use topical therapy like clotrimazole, which is available over the counter. And that's nice because it also gets Candida, some Candida albicans infections. Others, like haloprogrin, will get some tinea infections, but don't cover other fungi. So typically we use clotrimazole. Okay, staying on the tinea route, just from going to feet to head. Which is the preferred treatment for tinea capitis? Fluconazole, griseofulvin microsize, terbinafine, griseofulvin ultra microsize, or any of the above if you treat long enough. So it's really any of the above if you treat long enough, right? So the microsize, ultra microsize of griseofulvin work okay. Fluconazole, terbinafine work okay as well. It's usually the choice of the pediatrician or the insurance company that provided the medicine. But if you treat it long enough, usually most of those work. Malassezia, again, they're usually going to give you specific components in the vignette to make you think of malassezia. So usually low birth weight, they're on lipids, and they have an IV. Usually they're premature as well. So oftentimes they're asymptomatic, but sometimes they can show up as fever, respiratory distress, leukocytosis, thrombocytopenia, hepatosplenomegaly, which, in the NICU or the nursery, when kids get sick, they often have fever, hepatosplenomegaly, and thrombocytopenia. And so it's not really distinguishing. So they have to give you something else to make you think of malassezia, which is usually premature, or they'll say that they're on lipid formulation. Or they had to do a blood culture where they had to give them olive oil on the culture to allow it to provide the fatty chains to grow. The treatment for malassezia is you remove the catheter, you stop the lipids, and you give them amphotericin B. But again, it's not something you just normally think about without having the right epi-clues on the vignette. Sporotrichosis. So due to sporotrichum, I never really know how to say this, right? But it's SCH, right? So it should be like schedule or school. So it's skinky eye, right? Skinky eye? If anybody knows how to say this, anyway, I just like saying it. So again, This is going to be a percutaneous inoculation, usually from roses or moss. Remember, to distinguish this between sort of the same ulceronodular lesions that develop when you have Mycobacterium marinum from a fish tank. This is for someone who gardens. So the nodules appear along the lymphatics, similar to marinum, and then separate and drain. Berry pickers, farmers, florists, gardeners. So it's usually a single lesion that ulcerates and then goes to the lymphatic chain over days to weeks and progresses indolently over months to years. You culture it, and you can do usually saturated solution of potassium iodine, and the Red Book nicely spells out that it's 5 drops TID, PO, increased by 1 drop per day to total daily dose of 120 to 150 drops per day. Well, that might be easy for you. That seems very onerous, and so we just do itraconazole. And if it's extracutaneous, or sometimes you can use amphotericin B or longer-term itraconazole. That is a manifestation of a sporotrichosis infection. I know, right? Okay, parasites. Lots of parasites. So the protozoa are single cell. They replicate in the human host, and there's no eosinophilia associated with these. Toxoplasma gondii. So cat is the definitive host. You diagnose it by doing an IgM, and there are 4 different types of manifestations, right? So there's asymptomatic or mild disease, which is usually self-limited. There's pregnancy acquired, so which usually leads to congenital infection later in pregnancy. CNS disease, where you have multiple lesions, and when you're looking for toxo, you want to do MRI more so than CT. And then ocular toxo with yellow-white cotton patches. Usually the ocular disease is usually going to be in kids who have immune deficiencies, usually. So the fetal risk of transmitting toxo goes higher as you go through, if you acquire it later in your pregnancy. So first trimester, 25%, second trimester, half, third trimester, 2/3. However, the severity is inverse to this. So the later in pregnancy, the infant is much less likely to be affected. So even though they're more likely to get it, they're less likely to have clinical manifestations as opposed to early pregnancy, where you're less likely to get it, but if you do get it, you're going to have more symptoms. So you look for the following in a newborn: microcephaly, hepatosplenomegaly, rash, cerebral calcification. So if you see cerebral calcifications on your board exam, there are 2 diseases to think about in a newborn, right? You think of toxo, you think of CMV. Toxo, CMV, if you see calcifications. The toxo tends to be total, so it tends to be more widespread. Toxo total, CMV, circumventional C, CMV. Treatment is pyrimethamine, sulfadizine, and leucovorin, and leucovorin is mainly there to treat the side effect profile of pyrimethamine on the blood counts. So pyrimethamine, sulfadizine, and leucovorin. So autopsy result of a toxo invasion of the central nervous system. Oh, okay. I've never not washed my hands when entering a patient's room. I know this seems silly, but so if you've not washed your hands in a patient's room, you should say, no shot. Wow. So I don't know if there's confusion of the question or people don't actually wash their hands when they go see a patient, right? So on your board exam, when they ask you what should you do when you walk into a patient's room, the answer should be wash your hands. That's just, And you would think as an ID doctor, when you go to ID week, right, where it's tons of infectious disease people, adult and pediatric, that would be the one place you go to where everybody washes their hands when they leave the bathroom. I was ashamed. Oh yeah, it was a sad day. Anyway, one thing to remember about washing your hands with infections, right? So usually alcohol-based gel or foam is usually sufficient. If you have a case of somebody who has C. diff, alcohol-based gels or foams are not sufficient because the spores of C. diff can be resistant to that, and so you need to wash your hands with soap and water. See, we're trying to make those I've never somewhat relevant to your study, sort of. Anyway, Cryptosporidium, still on parasite. So this happens in immunocompetent kids, usually a self-limited diarrhea. The Wisconsin outbreak is the most famous. So back in 1993, there was About a quarter of Milwaukee got infected with cryptosporidium because of the water source. So that's probably the most famous. Typically lasts about 1 to 2 weeks, and the treatment is a 3-day course of nitazoxanide. If you're immunosuppressed, the infection can persist indefinitely. You usually use parabomycin and azithromycin, and then parabomycin alone. You diagnose this usually with usually most clinically relevant is the cryptosporidium antigen on a stool is the best test, and sometimes you can do an acid-fast stain of the stool, but more likely you just do a cryptosporidium antigen, which is usually linked to a Giardia antigen, and you get one of those. Because similarly, they're going to be epidemiologically in the same place. Usually you went swimming in a local pool or something like that. There you go, cryptosporidium. Cyclospore is relatively new in the world of infectious diseases. You see it on acid fasts. Typically, it'll be available on strawberries and raspberries. As a resident can attest, I eat strawberries and raspberries every day for breakfast, and so there's a chance I could have had cyclospore. I realize this is on the internet, and people are probably watching this, and it's not just y'all judging me that I have cyclospore running through my intestines. My wife's a lucky woman. Treatment for cyclospore is TMP SMX. Often it's also self-limited, so you might not need to do that. Plasmodium. So it affects the red blood cells. It's transmitted by the Anopheles mosquito, and there are 4 types. So what's wrong with this slide? Anybody? So there's actually 5 types. Right, but for your boards, you really only need these 4 types. There's a 5th type, Knowlesi, Knowlesi. But for your boards, these are the ones you need to know: Vivax, Ovale, malaria, falciparum. So there are truly 5 types, but for your board, it's really 4 types. This is where it happens, where the red is where malaria transmission occurs throughout the year. Falciparum is the most fatal of the 4. There's widespread chloroquine resistance. On the blood smear, you're going to see a banana gametocyte. Usually it's more than 1 infected red blood cell on the slide. Typically there can be multiple parasites in 1 red blood cell. If you see a schizont not on the smear, so schizont's not on the smear, if so, it's a non-falciparum form of malaria, so another plasmodium. We typically do thick and thin smears looking for malaria. The thick smear is to see if you have sort of a low parasitemia, then the thick smear will get if you have few infected red blood cells. And the thin smear is really there to help diagnose or detect exactly which plasmodia it is, and then the percent of parasitemia. So the more infected cells there are, the worse parasitemia that exists. The treatment for plasmodia usually is going to be quinine sulfate plus doxy for 7 days. You can do artemether and lumefantrine for 3 days, atovaquone and pogonil for 3 days, or mefloquine. Treatment, if you need to give an IV, if they're too sick to take oral therapy, then you do IV quinidine until they can take oral therapy. If it's in a chloroquine-sensitive area that they come from, then you can use chloroquine. That's the preferred drug of choice if you can. For malaria, Plasmodium malariae, it's the most commonly associated with nephrotic syndrome, so these are more associations. Nephritis can happen with any 4. Chloroquine you can usually use for Vivax, Ovale, and malaria. One thing to remember about Vivax and Ovale is that you have to give them primaquine as well, and the reason is because they can have hypnozoites in the liver that can cause relapses. And so Ovale and Vivax, think of them over and over, OV, Ovale, Vivax. So you need to give them primaquine to eradicate the hypnozoites in the liver, otherwise it continuously come back. So again, a smear showing some infected red blood cells sort of in the middle, and sort of the banana gametocyte there as a close-up. So you want to take prophylaxis for all types of malaria whenever you're traveling. Usually use mefloquine, or you use chloroquine if you're going to a sensitive area, and the CDC has a nice book, the yellow book, that you can use to help with that. If you do mefloquine, it's once a week for 3 weeks before arrival, and you continue it for 4 weeks after leaving the area. You could also do, that's nice because it's a weekly option. Doxy, you need to do it daily for a couple of days before arrival, and then continue it for about a month after travel. Or you could do atovaquone, pogonil, once a day for 2 days before arrival, and then continue it for just 7 days after you travel. Babesia. So this is, again, an intra-RBC protozoan, a Maltese cross pattern, which you'll sort of see there in the middle, sort of the Maltese crosses, which you'll see if they give you a slide. And again, it comes from an Ixodes tick, from rodents to deer. Again, Ixodes you think about for Ehrlichia, you think about for anaplasmosis, you think about for Lyme disease as well. Usually can show up as fever, sweats, myalgias. You can also have hemoglobinuria, which can be a predominant sign, so think about that. Emotional lability is common, and then treatment is usually Clinda plus quinine. If it's severe, you need exchange transfusion, and then you give those particular antibiotics for babesia. There's the Maltese cross in the middle. Entamoeba histolytica, so this is a fecal oral transmission. Usually it happens in individuals who are institutionalized, who are immigrants, who are men who have sex with men, and they'll usually give you some degree of epihistory or clues to suggest entamoeba. They typically they can develop a liver abscess, but you don't really see any amoeba in the liver aspirate. Typically, you want to diagnose it via serology. Metronidazole is very effective, so you want to give that. And so a liver abscess that can develop from entamoeba infections. Giardia, so again, similar epihistory that you get from crypto, campers, travelers, kids. An infected duodenum about 70% of the time. An infected duodenum, but about 70% of the time is asymptomatic. Usually you have fresh stool, do an OMP, or you do a Giardia-specific antigen. Treatment is, again, nitazoxanide. There's your little Giardia with a sort of crooked smiley face. Trypanosomiasis, so this is the African sleeping sickness that can happen from the tsetse fly. The Eastern African sleeping sickness can happen more acutely. The Western tends to be more indolent and develop over months. American trypanosomiasis is usually Chagas disease due to T. krusei. Often it's self-limited, but if they give you a unilateral firm edema of the eyelid or a monocyne, they'll give you that. Again, usually self-limited, but occasionally it can develop complications, namely it can develop heart block and lead to CHF. GI can have megaesophagus and megacolon and have CNS disease with delirium and hallucinations. And this is for the American, it's usually the reduvid bug or the kissing bug that you typically see with that. The monocyne. Okay, so the multicellular worms, these are the ones that do not replicate in the human body, but do cause eosinophilia. So this is what you think about when you look at the EOs on the CBC differential. So the roundworms, Ascaris, so Loeffler syndrome, this is where you have shifting infiltrates on your lungs, and you see that on your chest X-ray. You get serial chest X-rays, and you see a shifting infiltrate with, again, an eosinophilia. Enterobius, so pinworms, where you get rectal itching, so you can do the Scotch tape test. And the treatment for that is usually mebendazole or albendazole, but again, that's pinworms. Hookworm, caused by Necator, is where you get cutaneous larva migrans. You can have some systemic symptoms such as weakness or fatigue, usually an invasion from a direct contact with bare feet, usually. Whipworm or trichuris is diarrhea, abdominal pain, and rectal prolapse. Again, they'll give you that in the South. And then trichinosis, about 50 cases per year only, but about 4% of all autopsies is what you see. There's Ascaris. Eggs associated with trichuris, hookworm, and Ascaris. There's a cutaneous larva migrans you can kind of see on the top of the foot, sort of worming its way around. Nematodes or strongyloides. This is the only helminth organism that replicates in the human body, and 3% of Kentucky school children are infected with this. Again, eosinophilia is present, can persist for decades, and if you diagnose it, sometimes strongyloides can have systemic manifestations, so kidney disease, lung disease, osteoarticular infections. The treatment is usually ivermectin. Okay, another audience response. So this one is, I've never had a tattoo. So if you had a tattoo, that means you take a shot of espresso. Oh, wow. Oh, okay. So with tattoos, you worry about certain diseases, right? So hepatitis is what you worry about when you have tattoos. All right. Cystodes or flatworms. So Taenia solium, as we see with pork. There are other taenias as well, but usually pork is human infection. If it's adult cysticerci that you get infected with, it's tapeworm grown in the intestines, and so you get intestinal disease. If it's ingested eggs, you get cysticercosis when they hatch, go into the blood, and can maneuver to the central nervous system or eye, and that's where you get your really bad disease, because then those cysts die and cause problems in your central nervous system disease, including seizures. The treatment is praziquantel or niclosamide for the intestinal part, so that's if you ingest the adult worms. Albendazole or praziquantel with steroids for neurocysticercosis. So sort of the ring-enhancing lesions you see with neurocysticercosis and taenia. The flukes, so Clonorchus is the Chinese liver fluke where you get biliary obstruction. Again, this is going to be somewhere they give you somebody who traveled from usually the Far East. Schistosoma hematobium, which is where you get hematuria. So if you see someone with hematuria and may have traveled, think about schistosomiasis hematobium. Schistosoma mansoni is usually going to be in Africa, the Caribbean islands, Middle East, and South America. And then Schistosoma japonicum is in Asia, where you typically see Katayama fever. And that typically happens a few months after inoculation, presenting with fever, anopathy, diarrhea, and eosinophilia. Every now and then you'll have cirrhosis or esophageal varices associated with that. In order to diagnose schistosomiasis, you need to find the eggs in the stool, and then praziquantel is a drug of choice for anti-schistosoma infection. All right, viruses. So lots of viruses, and we'll go through these. Lots of viruses. Oh, but first, a question. A female patient is admitted with sickle cell pain crisis. Yesterday, she was exposed to a cousin with varicella. She has not had varicella and has not been immunized against varicella. When should she be in isolation? She should be isolation on admission. Days 8 to 21 after exposure, even without a rash. Day 1 to 10 after exposure, even without a rash. At the first sign of varicella, and then until her lesions have crusted over. At the first sign of varicella, and then until day 10 after the lesions have occurred. So first sign of varicella, and then until lesions. So the correct answer is B, days 8 to 21 after exposure, even without a rash. So again, it's when they're, D is not correct mainly because of the incubation period of varicella, and for those who are hospitalized, it needs to be 8 to 21 after exposure. We'll get into that. So VZV, varicella zoster virus. Primary infection is chickenpox that we all know and love. It typically is benign in children for the most part. It can be severe in adolescents, adults, pregnant women, and immunocompromised patients. In fact, most recommend treating these groups with either oral or IV acyclovir, depending on the clinical circumstances. But again, most of the kids who have chickenpox, I'm sure many of us in the room have had chickenpox. It was a self-limited illness, although it was not a pleasant illness. As most illnesses, I guess, aren't terribly pleasant. Varicella tidbits. So most common complication, as we saw from a vignette earlier, the secondary bacterial infections that typically occurs with group A strep, strep pyogenes, and Staph aureus. So look out for toxic shock or necrotizing fasciitis with that. The most common CNS complication is transient cerebellar ataxia and encephalitis with varicella. The incubation period is usually 10 to 21 days from exposure. So it can be up to 28 if you give immune globulin. And then hospital isolation is done 8 to 21 days after exposure. So again, this is sort of what it looks like. On the bottom is what you typically think about as chickenpox, many lesions, usually in different stages. The top is chickenpox, but that could also be breakthrough varicella, right? You tend not to have as many lesions if you have breakthrough varicella, usually due to the vaccine, so you get anywhere about 50 lesions as opposed to hundreds and hundreds of lesions that you typically see with wild-type varicella. In pregnancy, varicella is a big issue. It can cause pneumonia much more likely than the general population, so that's, again, why we treat pregnant females who have varicella disease. There are birth defects associated with affected with primary varicella during the first trimester, 8 to 20 weeks of gestation. So you get skin scarring, limb atrophy, microcephaly, cortical atrophy, seizures, and chorioretinitis. If a seronegative pregnant woman is exposed, you can give varicella immune globulin if given within 4 days of exposure, but you're not giving them vaccine because vaccine is a live vaccine. And so we don't give live vaccine to gestating individuals. You should give the varicella vaccine before they become pregnant. So again, some of the limb scarring that can be seen with congenital infection. Infants born to mothers who develop varicella either 5 days before delivery or within 2 days after delivery are at high risk for severe infection and should receive varicella immune globulin. So again, 5 days before or 2 days after. These infants are at high risk for severe infection and should get varicella immune globulin. Chickenpox treatment. So again, most kids don't need it, but if you have a second case in the household, it's okay to give acyclovir for 5 days. And again, if you're an adolescent or adult, are pregnant or have pneumonia, again, those are the more who can have a more complicating course. So you can give acyclovir for 5 days or valacyclovir. And if you're immunocompromised, you want to give IV acyclovir every 8 hours. Zoster treatment, so a normal host, you can give zoster acyclovir for about 10 days, which decreases new lesions and decreases the amount of pain. You can also give famciclovir as well for 5 days. We do not give steroids at all for zoster infections anymore. So again, there's the zoster sort of following along a dermatomal pattern of the thorax. CMV. So asymptomatic infection is very common, right? Anywhere between 0.5 to 1% of all babies born have congenital CMV. However, fortunately, most of them do not have symptomatic congenital CMV. The daycare center prevalence rates of CMV is very high. Most kids have some sort of seropositivity by the time they're 4 or 5 years old, up to 90%. Serious disease occurs in 2 circumstances. So transplacental infection of the fetus, which is the congenital CMV, or immunocompromised patients, namely transplant patients or AIDS patients. So congenital CMV really depends on maternal IgG status of mom. If the mom has antibodies, the risk of serious infection is extremely low. If they get a primary infection during gestation, then that's where you can have a severe form of congenital CMV that presents as the blueberry muffin baby, microcephaly, cerebral atrophy, hearing loss. Hearing loss is the most common long-term complication of CMV. Chorioretinitis. Again, this is the calcifications that circumvent the ventricles. If you have toxo can also do intracranial calcifications, but that's more diffuse. CMV is circumferential around the ventricles. IUGR, hepatosplenomegaly, you can get elevated ALT, you can get hyperbilirubinemia, and the treatment is ganciclovir IV or valganciclovir PO. And the treatment is usually for 6 months. CMV for normal adolescents, it can usually cause a mono-like illness. So typically you think of mono as EBV, but also CMV is the second common cause of that. In solid organ transplants, you can develop fever, malicious leukopenia, and develop significant viremia. This can lead to pulmonary and visceral organ disease and requires therapy, including valganciclovir or ganciclovir. Bone marrow transplant, you can get an interstitial pneumonitis, GI disease, and associated with graft versus host disease. If you're a bone marrow transplant and you get CMV pneumonitis, you get ganciclovir plus IVIG. For GI disease, you can give ganciclovir, and it works pretty well for esophageal disease, but if you have lower intestinal disease process, you can still give it, it's just less effective. And then for solid organ transplant recipients, you give ganciclovir is useful in pneumonitis and intestinal infections. Again, so CMV is it's problematic in newborns and if you're immunocompromised from a transplant perspective. Otherwise, it's a cold in immunonormal kids. Epstein-Barr. So this is the cause of mononucleosis in teens, what we all think about. More than 10% are atypical lymphocytes exist. About half of kids get splenomegaly, so you want to avoid contact sports until the spleen tip is no longer palpable. The monospot that we do is heterophile antibody positive. In most kids who are 4 and above, doing the monospot testing for kids less than 4 is not terribly sensitive. And so you can't trust that on your exam. EBV is associated with lymphomas, and nasopharyngeal carcinoma is associated with a lymphoproliferative disorder, especially post-transplant, and can be associated with hairy leukoplakia lesions of the tongue and HIV, or namely AIDS patients. Again, most EBV infections are asymptomatic, especially if you get it as a young kid. it's a cold. If you get it as a teenager, it more commonly presents itself as the mono we all know. After infection, the virus persists in the B lymphocytes for life. If you have a toddler who has persistent viremia, and that's usually detectable by EBV PCR of the blood, you consider an immune deficiency. The possibility of post-transplant lymphoproliferative disease occurs within 5 years in about 4% of kids, and we think that's due to the use of cyclosporin to prevent graft rejection. So this is going to be some erythema seen in the posterior pharynx of someone with EBV. This can be a rash of a kid who maybe got amoxicillin due to when they had an EBV infection. Serologies is how we sort of diagnose EBV for the most part, and we do an EBV profile. So if you get the VCA stands for viral capsid antigen. So if you get a VCA IgM that's positive, that likely represents acute infection or a very, very, very recent EBV infection. If you get the IgG for EBNA, or the Epstein-Barr nuclear antigen IgG, that turns positive usually weeks to months after you have a primary infection. And so if you're EBNA positive, likely you got that EBV infection weeks to months ago. So that doesn't explain your fever last week. And that stays positive for life. Your IgG VGA, your VCA IgG is what stays positive for life as well, but it takes a little while to develop. And so that's positive for life and occur before symptoms, and so it's usually not much help. So if you're EBNA positive, VCA IgG positive, that typically means you had an EBV infection a long time ago. What we just said. Okay. A male college student presents with cough, coryza, and conjunctivitis. His parents didn't believe in immunizations. A red macular. I thought I was going to. Yeah, never mind. Right. So sort of thinking about vaccines. Right. So vaccines are fantastic, but the people who develop vaccines didn't have medical education in mind. Right, because I can't show my residents what diphtheria looks like. I can't teach them what measles looks like. I have to use pictures. And if you notice, all the pictures are from like the 60s and 70s and 80s. And so as an infectious disease doctor, I love vaccines. As a medical educator, I don't like vaccines, right? Because I can't teach people what it looks like to show them tetanus. But vaccines are fantastic, don't get me wrong. I love them. They work really, really well is what I'm trying to say. And so good for them, but I can only teach you what measles look like. I can't show you a kid that we had last week with measles. So you don't usually hear ID doctors saying they don't like vaccines, but there's a reason for that. Sorry. So a kid is febrile and miserable, but otherwise stable. Which is the most likely etiology for his signs and symptoms? Rubella, measles, German measles, acute HIV retroviral syndrome, or HHV6? Oh, look, everybody said measles. Did everybody really say measles? That's fantastic. That's great. Strong work. It'd be funny if nobody said measles. Okay. So other herpes viruses. So we talked about EBV, we talked about CMV. Human herpes virus 6 causes roseola, right? So really, really high fever, fussy kid, fever goes away, rash pops up. Roseola, HHV6. Often causes febrile seizures because of the fever. Every now and then can cause meningoencephalitis, and not only immunocompromised, but also in immunocompetent kids. HHV8 can be responsible for Kaposi sarcoma in aged patients. Rubella, also known as German measles, and people still use German measles. I'm not entirely sure why they still use German measles to distinguish it from measles, and so as opposed to calling it rubella, but there it is. Rubella is German measles. You get a red rash, posterior auricular suboccipital lymph node enlargement along with fever, and you get an oral enanthem called the Forsheimer spots, so just sort of red spots in your mouth. Congenital rubella, you're more likely to get it earlier in gestation and can manifest as cataracts, cardiac abnormalities, and glaucoma. You can also have hearing loss and neurodevelopmental delays. The second trimester, You usually have neurologic problems. And then third trimester, the risk is high, but usually no sequelae with that. So maybe with ocular findings for that. Okay, audience response. I've never fallen asleep during a lecture during residency. So that means if you fell asleep during a lecture in residency, you have to take a shot of espresso. You probably need it if you fell asleep during. No, let's just say residency, not med school, because I was guilty of med school, but not residency. I don't know why. Probably more mature. Who knows? Oh, wow. Really? Man. The 15% must be the residents who are here from our program. So, strong work, guys. I actually don't have a clinical relevancy for this particular question. Other ones I was able to translate something, but not this one. I apologize. We go back to rubella. So the postnatal rubella with a maculopapular rash, again, old person. Those with congenital rubella tend to have some sort of endocrinopathies, right? So they typically have diabetes or have some sort of increased risk of thyroiditis. The way I remember this is rubella. So rubella is German measles, right? So rubella. I think of Bellatrix Lestrange, who was a Harry Potter character. I don't know if any Harry Potter people out there. But Bellatrix Lestrange was played by Hella Bonham Carter, who's British, so across the pond, British, German, measles. And then they made her look like she had proptosis, like really big eyes. And so I think that as a thyroid or endocrine disorder, so endocrine, diabetes, thyroid. I'm not saying it works for you. I'm just saying this is how I remember these things. So just if you want to use it, great. If you don't want to use it, that's okay too. To each his own. Rubiola, measles. Cough, coryza, conjunctivitis, the 3 C's. Koplik spots is a hard C, I guess, or a K, I guess. Oh. Red macular papular rash that typically begins at the hairline and goes down. So starts here and goes down. It's most severe in those who are vitamin A deficient. And actually the recommendation is to give vitamin A for kids who have measles. Immunoglobulin is effective if given within 6 days of exposure. It's very, very contagious. And the Koplik spots are sort of the blue-white lesions you see on the buccal mucosa. And then a rash started on the hairline and went down. Adenovirus, so very, very, ubiquitous, easily transmissible. It's a common cause of URIs, especially in toddlers with pharyngitis. You can have a pharyngoconjunctival fever, usually due to adenovirus 3, where you get pharyngitis, conjunctivitis inherent in its name, typically during the summer and typically during swimming season. Diarrhea is due to adenovirus 4041 and can be responsible for some intussusception episodes as well. And then types 11 and 21 can cause hemorrhagic cystitis. That's often confused with post-strep glomerulonephritis. So adenovirus is very ubiquitous. It tends to cause a multitude of clinical manifestations. URI, paraconjunctival fever, and diarrhea are the most common. The respiratory viruses can include adenovirus as well because it causes URIs. But RSV, respiratory syncytial virus, peak winter and spring, can cause an interstitial pneumonitis and usually diagnosed via nasal secretions. You could do a nasal swab, nasal washing, or a PCR from that. There's no real treatment for it. It's more supportive care, as you probably all have taken care of kids with bronchiolitis due to RSV in the hospital. But the prophylaxis is now available for monoclonal antibody palivizumab. And usually the recommendations change every so often. Most recently, it fits there as a preterm birth, less than 29 weeks estimated gestational age. If they have hemodynamically significant congenital heart disease, if they're less than 32 weeks EGA with chronic lung disease and require supplemental oxygen for more than 28 days, or you can consider for anatomic pulmonary disorders or neuromuscular disorders. And that's for prophylaxis. Metapneumovirus, it's a very common cause of RSV negative bronchiolitis. It looks quite similar. The epidemic's usually late winter, early spring. You could do PCR testing for that, and again, supportive care. Clinically, it's hard to differentiate metapneumovirus from RSV. Other respiratory viruses, paraflu, types 1 through 4. This is what you'll see as the cause of croup. So if you see a kid with croup, it's due to parainfluenza, and it usually occurs year-round. You can give Dex for croup. Coronaviruses is also the most common cause for common colds. Occasionally have fever. and you don't need to worry about SARS yet. The flu, right? So we don't use amantadine or amantadine anymore. We use also oseltamivir, zanamivir for our flu treatments, as we typically use clinically all the time. Zanamivir is still effective for both A and B. Resistance wasn't very common this past year. The best way to prevent flu infection is to immunize. Just out of curiosity, at your institutions, does anybody here have a mandatory flu vaccine at your hospital? Yeah, or a mask, yeah, okay. Just curious. Remember, kids who are less than 9, if they've never been immunized for flu, they require 2 shots 1 month apart. Enteroviruses, so some Coxsackies, Echo, Entero, and polioviruses. Again, these are within a group of enteroviruses. So hand, foot, and mouth disease, fever. You get vesicles of the buccal mucosa, tongue, lips, and gums. You also get a red rash. Sometimes they become vesicular on the hands and feet, and sometimes in infants they develop on the diaper area as well. These are due to Coxsackie A or enterovirus 71. There's an older individual with ulcers on the tongue, lateral side of the tongue, and then lesions on the hands as well. So notice they're sort of vesicular, but not quite what you think of with herpes simplex. Other enteroviruses, they can cause acute hemorrhagic conjunctivitis, also herpes angina, which is usually Coxsackie A infection, where you get tiny vesicles on the pillars of the tonsils. Usually you also have a sore throat with that. You can also develop myocarditis and pericarditis due to one of the enteroviruses, namely Coxsackie B or echovirus. And this is a very common cause of aseptic meningitis. So whether it's enterovirus or par-echovirus, there's certainly a big cause of that. This young lady who had, this is actually my daughter, who had vesicles on her leg. And as a nerd, I took a picture. Thought I'd share it. So this is plaques that can develop with some enteroviral diseases gone rampant. Polioviruses, so polio we typically don't, we don't see anymore. Right? We just don't see it, but the boards will ask you about polio, even though I've never seen a case of polio. So it's usually aseptic meningitis with flaccid paralysis without reflexes that begins proximally and goes distally. And you typically have respiratory involvement, so the whole iron lung way back when. A case definition to diagnose polio, you have to be less than 6 years of age, have fever at onset of disease. You have a descending paralysis within 4 days, and you have residual neurologic deficit for more than 2 months after onset of paralysis. And you recover for the polio from stool, throat, or CSF. And you can also have a post-polio syndrome years after your acute illness. Mumps. So it's usually unilateral or more commonly bilateral parotid swelling. About a third of postpubertal males get epididymoorchitis that's usually unilateral as well. A third of adolescent females can get mastitis as well. Deafness occurs in about 4 to 5% of kids in one study. And one thing to not forget, if you have parotid gland enlargement in an adolescent, consider mumps, but also consider bulimia as well. So it's a large parotid gland. Kid. Another question. So a male college student presents with swollen parotid glands and testicular pain with a mild swelling. He is febrile and miserable, but otherwise stable. Right? So in your head, you're thinking, oh, this is mumps. This is great. That's not the question. The question is, what is the most likely reason for his mumps? So either A, he hasn't been vaccinated, B, it's been more than 10 years since his last MMR, C, he's immunocompromised, D, vaccine failure despite 2 doses, or E, a non-vaccine strain of mumps. He hasn't been vaccinated yeah. So again, most people have been vaccinated for MMR, measles, mumps, rubella. And so it's likely that he hasn't been vaccinated. It's more likely that his vaccine failed. And so just because you get a vaccine doesn't mean it's 100% effective. Most are 80, 90% effective, but not 100% effective. So there's the whole idea of herd immunity. So if everybody's vaccinated, it's less likely for kids or people to get these diseases caused by vaccines. When you have a vast majority of the population vaccinated, sometimes it will happen that you get an infection due to a vaccine-preventable disease. And that's one of the arguments that a lot of anti-vaccine proponents use is that, well, my kid got the vaccine, yet he still got the infection. Well, the more and more people that are vaccinated, sometimes the disease still exists, and just because you get a vaccine is not 100% effective, but the more people that get the vaccine, the more herd immunity that exists. Parvovirus B19. So this is what causes erythema infectiosum or Infectious disease. And once the rash appears, the child is no longer infectious, no matter what the daycare tells you. So remember that this infects red blood cell precursors in the bone marrow, so you're going to have an anemia, but it shouldn't cause a leukopenia, it shouldn't cause a thrombocytopenia. It should be focused on red blood cell precursors and anemia. You can get acute polyarthritis of the hands, knees, and feet that resolves over a few weeks. 5 to 10% of infants, when mothers get it in pregnancy, a primary infection will have fetal loss with high drops. The way to diagnose parvovirus is usually IgM, and then sometimes we use PCR as well. So again, when the rash appears, the child is no longer contagious and tends to be fairly happy with that. And so, all right, continuing with the viruses, we're going to go to arboviruses. So these are sort of the mosquito-borne illnesses that we can see. So from a historical perspective, looking at West Nile activity in the United States, sort of started in the Northeast, where all really popular trends start in New York or LA, but not in this case. But this one started in the New York area, and then went across the country. Typically see it in the South. We get a lot in Texas here, apparently, and then kind of all over as of 2012. So it's pretty widespread. But usually if they're going to give you West Nile, they're going to give you an area. So again, sort of in the upper Midwest, the Northeast, the South of the California, which I guess is most of the United States. But they're not going to give you someone in, Oregon with West Nile. That's just silly. So clinical features of West Nile, about a fifth infected will have an illness, but the rest are asymptomatic. So 80% of the people with West Nile infections are asymptomatic, which is great. So the mild illness, you can have malaise, anorexia, headache, myalgias, and rash. There's severe infection usually manifested by neurologic disease, where they have mental status changes, fever, weakness. It can have really bad sequelae from a neurological outcome with this. It's more severe in older adult patients. They can have cranial nerve abnormalities and seizures as well. Diagnosis is usually done with serology, so IgM. You could do it of the serum. You could also do it of CSF if you have it. And CSF tends to be more specific for acute disease because you typically don't have floating antibody in your spinal fluid if you don't have an active infection, whereas the IgM and serum can be positive for many, many months, if not years. After the disease is well established in the community during the time frame, usually, again, when mosquitoes are present, which is usually in the summer, the diagnosis is usually straightforward, and you don't usually need to do serologies. You can also do PCR of West Nile as well in certain labs. But the treatment is supportive. There's really nothing we can really do about this. And again, as an ID doctor, we like to still have jobs and work and pay, and so you can always consult ID, and we'll stay supportive care. Look, with vaccines, we just don't see any infectious disease anymore. So, I got to feed my family. So please consult ID at any point in time. Chikungunya and Zika viruses, this is just more for edification. These shouldn't be on your exam. Chikungunya might be because it's been around for a little while. Again, both mosquito-borne. The unique thing about chikungunya is they're going to come from somewhere, usually somewhere in the Caribbean islands with fever, rash, myalgias. Zika is unique in the fact it can cause congenital disease, but that probably will not be on your boards just yet. Hantavirus, so again, desert Southwest, they need to give you that, or an adolescent with severe hemorrhagic pneumonia, again, in the Southwest. Dengue is the leading cause of illness in returning travelers from the Caribbean, Latin America, and South Asia. Again, most are asymptomatic, but if it is symptomatic, it's usually an acute febrile illness that lasts for about a week. One key feature is retroorbital pain. They describe very specific retroorbital pain when you have dengue. If you have hemorrhagic fever due to dengue, this is where you have shocking mucosal bleeding, and usually it's the second time they had dengue where they have the most severe symptoms. The diagnosis is usually IgM or PCR, and unfortunately there's no direct therapy, it's just supportive care for dengue. No. Okay, our response. I've never had chitlins. Even though I'm from Louisiana, born and raised, love Louisiana, I've never had chitlins. So if you've had chitlins, the answer is A, take a shot. Interesting. Oh, wow, a quarter of people have had chitlins. That is impressive. Okay, continuing on the viruses path. So HIV. So HIV-1 is far, far, far more common than HIV-2. On your test, it'll be HIV-1. One question that we get asked a lot clinically, and then also you'll probably on your exam, is what do you do for a needle stick in a public place? You wash it, you get baseline serologies for HIV, Hep B, and Hep C, and then you watch. You don't give antiretrovirals. According to the Red Book, there are really no reported cases of HIV being contracted in a public space and exposure to a needle. If you get an MRI and you have basal ganglia calcifications, that suggests HIV. If you have very high immune globulins, that also suggests HIV, especially if it's positive quantitative immune globulins across the board. It suggests HIV. So transmission, we've gotten really good at preventing mother-to-child transmission of HIV, which is fantastic. It used to be 25 to 40% if mom is not on treatment. Mother-to-child transmission decreases significantly to about 8% if someone's on zidovudine alone. It decreases even more to less than 1% if they're on highly active antiretroviral therapy for mom. Babies born to mothers who have HIV, they get 6 weeks of zidovudine or AZT, but they do not need pneumocystis prophylaxis. It's 6 weeks of zidovudine. Acute HIV infection is the earliest phase of HIV infection that happens. This is where you have a very high viral load and you have the absence of HIV-1 specific antibodies. So usually it shows up as a pretty bad viral illness, so it looks like someone who has mono. They feel fatigued, they might have a little bit of fever, they have myalgias, they just kind of feel like crud. And that can be an acute HIV-1 infection. This is a reason why we still have the spread of HIV is acute HIV infection, right? Because you have a high viral load, you have no antibodies, and you don't know that you have HIV. And so that's a good opportunity to spread HIV. In fact, it's where most all of transmissions occur. In fact, it's a 26-fold increase of transmission in someone who has acute HIV infection. For diagnosis, so and then baby born, so in addition to a baby born to a mother with HIV, you give the baby zidovudine for 6 weeks, and you test baby at 2 weeks, 4 weeks, 4 months. 2 weeks, 4 weeks, 4 months with the HIV qualitative PCR. Qualitative just mainly because you want to know presence or absence of HIV. You don't necessarily care about viral load, and a lot of quantitative PCRs go down to, dozens or hundreds of copies, which if you have a baby with HIV, they're usually going to have hundreds to thousands of copies, but you want a qualitative HIV PCR to look for presence or absence of HIV. If it's positive, you repeat it, and if it's positive again, it's confirmed that they have infection. If it's negative at 4 weeks and 4 months, then you have HIV essentially ruled out per the guidelines. Or if you have a kid who is at least 4 months old with 2 negative PCRs that are at least 4 weeks apart, then that's considered negative. We don't do Western blots anymore. One way to prevent HIV transmission is to have the mom do not breastfeed in this country. Also, we tell parents and moms to not pre-masticate baby's food and give it to baby. There are some case reports of pre-masticated food that have transmitted HIV. In older kids and adults, the current screening test is a combination P24 antigen and antibody test. So this is a 4th generation test. So again, we don't do enzyme-linked immunosorbent assays or Western blots. This is the 4th generation test. So this is the diagram of that. So the idea is that with the 4th gen test, we're looking not only for antibody, we're looking for antigen as well. right? So a lot of times we test things, what we've talked about doing serologies, IgG and IgM, depend on us responding immunologically to that infection. So we're looking for antibody response. Same thing for HIV, we're looking for antibody response. But the nice thing about the 4th-gen test, it also looks for antigen. So even before you produce antibody, it can detect enough P24 antigen to call it positive. So one great thing about that is that we can detect HIV infection sooner. And so we can identify those people, kids, who might have acute HIV infection that would have been missed otherwise by doing just antibody test. And so the better testing we have, the earlier we can detect HIV, and the sooner we can diagnose and treat. And so going back to that prior one, when you have a 4th-gen test positive, you confirm it, and then you do CD4 count to check their immune system status, and then a viral load and resistance profile to see what antiretrovirals you can use and then start therapy once those results are known. Combination antivirals are typically the best. You always get a resistance profile before starting or changing antiretroviral therapy, so that was the genotype that we talked about. You monitor CBC, CMP, viral load, CD4 count every few months, and it's okay to change meds to decrease the pill burden, right? Because a lot of times, especially in adolescence, it's about compliance. And I don't know about where y'all are from. Where we're from, compliance in adolescence isn't that great. And so we have to make sure we ensure that we have a compliant patient, and so we try to do our best to adjust the pill burden so they can be more compliant. And life expectancy can be normal. This can be a chronic disease if managed well, just like hypertension or chronic kidney disease. Post-exposure prophylaxis for HIV children. If they get exposed to measles, if they have severe HIV, so a very low immune system or a low CD4 count, they can get 0.5 cc's per kg of immune globulin. If they're asymptomatic HIV, then they get a lower dose to 0.25 mils per kg of immune globulin. Tetanus, if they have a low CD4 count or a low CD4%, you give immune globulin regardless of their vaccination status. And for varicella, you give varicella immune globulin if not previously vaccinated, or if they're a moderate to severe immune suppression, so a low CD4 count. Again, when it comes to immunocompromised patients, what we typically think of in immunonormal patients is sort of thrown out of the window. And so for HIV patients, we do know how to treat some of these from a preventative standpoint. The complications from HIV are mainly the opportunistic infections, and so pneumocystis is the most common. Usually it has about 5 months after infection. Lymphoid interstitial pneumonitis, or LIP, is the second most common. Typically occurs only in infancy. Recurrent bacterial infections, cryptococcal meningitis. Zoster is frequent, but not an age-defining illness in kids. And then progressive multifocal leukomalacia is rare, but can happen as a complication of HIV and worsening disease. So again, also talks about having Kaposi sarcoma, which again, HHV8, human herpes virus 8 related, or leiomyosarcoma or leiomyoma, which is EBV related. All right, zoonoses. So the World Health Organization Committee of experts met and defined zoonoses as those diseases and infections naturally transmitted between animals and man. So there are over 200. We'll go through each one in detail. So typically they're transmitted by direct contact, biting insects, inhalation, or ingestion. So in general, humans can also transmit diseases to animals, namely Campylobacter jejuni can spread from owner to dog. So just be aware of that. The risk of transmission depends on several factors, so how frequently you contact the animal, the intimacy of the contact, and then the animal having contact with infected animals. So if you sleep with your rat, you might have more of a risk to develop rat bite fever. We had a case in fellowship. Kid had rat bite fever, slept with a rat. I look it. People have turtles apparently too. So, yay, infectious diseases. Overall, the risk is low in United States households. However, almost over half of all households have a dog or a cat. I understand the dog, I don't understand the cat. I don't know. I make fun of cats later, so I'll save it for that. 15 to 20% have pet birds as well. Other pets, as you can see here, many pets. Monkeys, turtles. Rabbits. So we have a rabbit that comes in our backyard every so often. Her name is Rosa. So I'm trying to teach my 7 and 4-year-old that rabbits are infectious. They don't seem to care that much. So we think of Pasteurella, Multocida, Salmonella, Yersinia, tularemia, so Francisella tularensis. So one thing you think about, again, tularemia, think about it in where again? Missouri, Arkansas, Oklahoma, Kansas. Speaking of Arkansas, a question. An adolescent male from Arkansas has been getting sick over the past 4 to 5 days. He is an avid hunter, especially in the late summer and fall. He was treated with antibiotics recently for a minor skin infection on his thigh. He has fever, hypotension, tachycardia, hyponatremia, and altered mental status. He doesn't have a rash. Which of the following is the most likely diagnosis? Tularemia, blastomycosis, Bartonella henselae, sporotrichosis, or ehrlichiosis? Oh gosh. That was right. We just started talking about zoonoses and tularemia, and then there's a question about ehrlichiosis. Golly. I gotta tell you, that guy. So again, remember the boards, they're gonna have questions about all kinds of things, not gonna be in a particular category. So what was the reason for this kid having ehrlichiosis and not tularemia? So I usually have a smaller audience. So it's mainly how sick the kid was, right? So they had hypotension, hyponatremia, and that's what you think about rickettsial disease, right? So that's going to be something that causes tularemia doesn't do that. It causes your ulceroglandular, oculoglandular ulcerations. Rodents, mice and rats can spread babesiosis, plague, again, Yersinia pestis, with mice and rats, and leptospirosis and hantavirus. Again, the hantavirus is going to be in the southwest. Gerbils can spread salmonella and leptospirosis. Guinea pigs and hamsters do some of the same ones, and also do lymphocytic choriomeningitis or LCM. Reptiles, including turtles. Remember, turtles, iguanas, salmonella. Turtles, iguanas, salmonella, and they can shed for a very long time. The FDA, there's now an FDA ban for commercial distribution of turtles. So we've seen a lot of decrease in salmonella-related disease due to turtles, but we see a lot more due to iguanas, lizards, and snakes. So again, iguana, turtle, lizard, salmonella. Ferrets, they are very popular. Many people have them in their homes, but they are also a good transmitter of influenza, salmonella, campylobacter, and rabies. Okay, audience response. What is the best ice cream brand around here? And I had to do a little research on this one to give you the options. So ice cream. So we talked about earlier that I eat Bluebell every night, so I might have a predilection, but don't let that bias your opinion. What is the best Bluebell ice cream around here? Bluebell, Lick, Milk Cream, Melt Ice Cream, Amy's, or other? Bluebell or other? Anybody give me an example of other? Baskin Robbins. Oh wait, can we talk about Baskin Robbins? That's a commercial. I don't want to advertise for Baskin Robbins. I guess I'm doing it for Bluebell and Lick and all the others. Okay. So Amy's is good. I found it in Austin, and it's probably other places as well. And then I also discovered Lick in Austin as well. It's very, very tasty. So anyway, ice cream, you can't go wrong with ice cream, I don't think. Unless it has listeria in it. Well, I probably ate some listeria, and I was fine. It's okay. Bird flu. The most common is H5N1. Many birds were infected. There have been about 400 cases in the past decade or so. Luckily, spread from human to human is very limited. We have resistance to the usual things that flu is resistant to, amantadine, rimantadine. We typically use oseltamivir to treat, even though there is some resistance developing to even that. And so hopefully we can prevent the spread of these zoonoses as well. Cats. So cats can spread ringworm or microsporum. Most of the cats in catteries, I had to look at. Anybody heard of a cattery? Anybody have a cattery? I know one person that probably has a cattery, but yeah. So they spread ringworm. So just be aware of that. Cats can also spread Pasteurella because a majority of the cats carry that in their mouths. In recent studies, the most common organism in cat wound infections was Pasteurella multocida, followed by Staph aureus. And you treat all cat bites with amoxicillin clavulanate. Or if they have a pin allergy, you typically do TMP SMX. Again, Pasteurella is more likely from cat bites mainly because when cats, more so than dogs, because when cats bite, they tend to puncture and go deep, and so it's harder to clean those areas as opposed to dogs. It's more an abrasive bite, I guess, to some degree, and so those are a little easier to clean. And then again, we mentioned earlier, cat scratch disease also caused by Bartonella. Again, 40% of cats have positive antibodies for this, and so they easily spread it by either bites, scratches, or can be carried by fleas on the cat. And again, Bartonella can cause a number of different manifestations. We talked about regional adenopathy from the site of where they were scratched. Also, fever on an organ, but also cause hepatosplenic disease and osteoarticular infections. Again, all the things that a cat can cause, including toxoplasmosis and Pasteurella, are the two most common ways to think about. Again, it's rapid development of swelling, erythema, and pain, along with some discharge. It can also, if deep enough, cause arthritis, septic arthritis, and osteomyelitis. And we typically treat with penicillin. If you grow it, it's typically sensitive to penicillin, but empiric therapy is usually amoxiclav because it takes care of Pasteurella as well as other anaerobes or bacteria that might live in the animal's mouth. Cats also have other things that are non-infectious to humans: feline immunodeficiency virus, leukemia virus, and a lack of empathy. Apparently, some people love cats. I don't know. I don't think I have a question about who's a cat lover in here, so you can stay anonymous if you would like. Dogs? I mean, look at this dog. I mean, how could that dog do anything to anybody? Actually, that's my dog. His name is Wilson. He really can't do anything to anybody. He's probably the most squeamish yellow lab you'll ever seen. So if you put a frog next to Wilson, Wilson would run away. If you put anything next to Wilson, he would run away. But he's so cute. So while theoretically he can give you all these things, he really can't. So again, thanks to the movie Cujo, we all thought everybody gets rabies from dogs, but they don't. But when humans do get rabies, it's a very serious illness, and in fact, mostly fatal. It causes an acute encephalomyelitis where you get excitation after restlessness. You get severe spasms of the larynx and pharynx when a person sees water or food, so the hydrophobia that exists. Usually diagnose it with Negri bodies and the cytoplasm of neurons taken from a biopsy of the nape of the neck. So post-exposure guidelines, if you're exposed to dogs, cats, or ferrets that might have an unprovoked attack and they're suspicious for rabies, you would begin prophylaxis immediately. If they're healthy and available for 10 days of observation, you do not do prophylaxis unless the bite or exposure is to the neck or head or the animal develops signs of rabies. If they're unavailable for observation or testing, this is when you talk to your local health department and let they help you decide whether or not prophylaxis is necessary. For raccoons, foxes, skunks, coyotes, and bats, you consider them rabid unless available for testing and proven not to be infected. For other particular animals, such as rodents, livestock, rabbits, and other mammals, you want to consider on an individual basis. And this is, again, where you talk, this could be an option on your test, where you talk to the public health officials so they know the likelihood or availability of the rabies vaccine or rabies virus being present in those particular animals. If you find a bat in the room and there's no sign of the bat, but you slept overnight and you found the bat the next morning, you give the prophylaxis, right? Because you don't know, especially in kids, you don't know if you were bitten overnight while sleeping. If you're kind of hanging out during the day and you see bats flying around you and it's not a problem, you really know when a bat has bitten you. But if you sleep overnight in a room or a house with a bat, you need prophylaxis. And that's a picture of a bat in my house that we slept with. And we didn't really know it was a bat in the house till the day before we were going on vacation. And so we got to we got to go to the emergency room and get rabies shots. My 7 and 4-year-old loved it. Even though they got shots, they really did love it because they got to stay up past midnight because we found it like at 8 p.m. And so then we went to the ER and went through all the steps of getting immune globulin and vaccine. And by the time we got home, it was about 1 a.m. It's fantastic. So what do you give for post-exposure prophylaxis? You give immune globulin, 20 units per kg, with as much of the dose as possible given to the wound, and the rest of it giving intramuscularly. And then you give rabies vaccine and the deltoid on day 0, 3, 7, and 14. There used to be a 5th dose, but they no longer recommend that. So it's 4 doses, 0, 3, 7, 14. Toxocariasis. This is an intestinal roundworm of dogs and cats. Their eggs can be excreted and found easily in the cracks of floors and under rugs and in the dust. So when kids playing around with the floor and doing whatever they do, they can certainly get exposed to these particular infections. And then you can get visceral larval migraines, especially in kids who are young and have a pica history. So we're going to skip this in the interest of time. Just kind of goes through how the puppy history gets infected and then is able to secrete toxo. Then how it migrates aimlessly through humans, but does cause these systemic symptoms, including fever, hepatomegaly, eosinophilia, and elevated IgG. So again, this can be a migratory pneumonia. Like I remember something else we talked about, a migratory pneumonia, right? Ascaris, right? So a Loeffler syndrome, so a migrating pneumonia on exam or on radiographs, similar to toxocariasis. You get elevated eosinophils and immune globulins. You can do an enzyme-linked immunosorbent assay to diagnose it, and the treatment is either albendazole or mebendazole. So just a general healthy pet ownership. Make sure you wash your hands before eating and smoking, or you can stop smoking and just wash your hands before you eat. Make sure you have your pets on flea medicine and avoid any direct contact with vomit, feces, or urine. Tapeworms. So humans ingest dog or cat fleas that contain the larvae, and they develop abdominal pain and diarrhea. Usually solitary worm of about 4 to 28 inches in length of the large bowel, and praziquantel is usually the treatment of choice. So again, back to the Taenia solum, which we talked about before. So it typically is eaten by the pig where the eggs hatch into duodenum, and then they migrate to the blood and lymphatics, and then the skeletal muscle and myocardium. And then humans eat pig meat, and the larvae attach to the small intestine of us and mature in a couple of months. And then the tapeworm itself can be 4 to 9 feet in length. And then treatment is praziquantel. So I like this quote is, infection of the pork tapeworm is ordinarily asymptomatic except for the discomfort, inconvenience, or embarrassment resulting from the graviculatids crawling out of the anus. And occasionally intestinal obstruction may occur. And one thing we do in the South is a couchon de lait or pig roast, and my wife's family does that on an annual basis. So there's a decent chance that we might have proglottids at some point. Heartworms. So these live in the chamber and large vessels of the right side of the dog heart and spread to humans by mosquitoes. So numerous cases in the humans have been reported, particularly in the southeast, and show up as coin lesions in the lung. So again, part of the reason you want to have good, healthy pet ownership is to prevent fleas. Fish and shellfish. So Cryptosporidium, we talked about. Mycobacterium marinum, again, fish tank cleaning. Salmonellosis, right? So that can happen with fish and shellfish. And then Vibrio. That's one we typically see with Vibrio vulnificus that happens in folks who have exposure to seawater animals and are fishing, develop a cut on their hand, develop really bad wound infection. That's typically due to Vibrio. So the common ID syndromes we've kind of already alluded to a lot of the times with some of the bacteria and fungi and viruses we talked about. So hopefully it won't be that long. So common ID syndromes we'll talk about. Fever without a source and a neonate. So if fever without a source, think sepsis, and they have to have a full workup, right? Less than a month of age, fever, full workup, and the things you kind of think about are group B strep, think about E. coli, think about listeria and the really young ones. Also group A strep and staph later on. For the neonates, you hospitalize and give empiric antibiotics for about 48 hours until cultures are negative. In 1 to 3 months, you use your clinical judgment. Each institution usually has their own sort of algorithm based on what they want to use for those kids 1 to 3 months. Viral is a much more common etiology of infection than bacterial. UTI is usually the most common serious bacterial infection we see at kids this age. And then for kids older than 3 months, it depends if they started their vaccination series. And again, viral, far more common than bacterial infections. For CNS infections, so there's meningitis, right? So inflammation of the leptomeninges, where you get fever, headache, stiff neck. Then there's encephalitis, which is different than meningitis, where you have inflammation of the brain itself. And that's where you have, again, fever, headache, stiff neck, but you also have altered mental status more commonly. And the boards will usually distinguish between the two. And then sometimes you can have meningoencephalitis, where you have inflammation of both. So acute presentation typically is you have symptoms for less than 24 to 48 hours, fever, headache, lethargy, and stiff neck. You have a non-focal exam, you do empiric antibiotics if the LP is abnormal. For chronic, usually the presentation is that subacute or chronic up to 2 months in duration. They usually have a headache, sort of focal on one side with focal neurologic signs or symptoms. Seizure activity can develop, and usually do imaging first to kind of see what you're dealing with, if it's a space-occupying lesion or whatnot. And then if the imaging is okay, then you could do your lumbar puncture. So acute presentation with focal findings, you give antibiotics first and tap later. So for acute bacterial meningitis, the epidemiology most of the time occurs before 15 years of age, and it's strep pneumo in all age groups. So bacterial meningitis, strep pneumo. Bacterial meningitis, strep pneumo. Even if they've been vaccinated, strep pneumo. Neisseria meningitidis happens as well, typically in closed populations. So you'll see someone who's at a boarding school or a college kid. And Haemophilus influenza, again, was the most common reason for bacterial meningitis, far less so because of the Hib vaccine. So again, there you go. Meningitis is due to strep pneumo most of the time. Neisseria meningitidis, group B strep, H flu, and listeria. So again, it's the idea that the pathogen crosses the blood-brain barrier, and you have insufficient opsonic and phagocytic activity in the CSF that results in the organism rapidly dividing. And so this is why it's very difficult to treat as well, because not only does the blood-brain barrier typically keep out bacteria that cause infections, whenever you give systemic therapy, it also typically keeps out antibiotics that are trying to help the infection. And so it becomes very, it's sort of a acts against itself. So brain edema can occur mainly because of the capillary leak that can happen because the inflammatory process develops once the infection is set in, and you can have increased intracranial pressure because of the edema, and then the reduced cerebral blood flow that can cause some of the sequelae that we typically see with infarcts. It can spread from sinuses or mastoids. If someone has hearing devices, cochlear implants, that's a risk for bacterial meningitis as well, mainly due to strep pneumo. So predisposing factors to meningitis, in particular bacterial meningitis, complement deficiencies, Neisseria meningitidis. So if you have a kid with recurrent Neisseria infections, think a complement deficiency C5 through C9. Splenectomy, you think about encapsulated organisms, right? So strep pneumo, H flu, Neisseria meningitidis, and enteroviruses. Sickle cell disease, they're at risk for strep pneumo and H. influenza infections. And then HIV, cryptococcus, toxoplasmosis, histoplasma, TB, and syphilis. So when you have bacterial meningitis, you do a spinal tap, and you get your white blood cell count, you use your glucose and your protein. Those are the main things you look for when you're determining whether or not somebody has bacterial meningitis. For bacterial meningitis, you're typically going to have hundreds to thousands of white blood cells, mostly segmented neutrophils. You're going to have a low glucose and a high protein. That's typically what you see with a bacterial meningitis. For aseptic or viral meningitis, you have far fewer WBCs. Every now and then it can get to 1,000 or 2, but not very commonly. On your boards, it'll give you a lower WBC count. Sometimes it can be a left shift, so more neutrophils at the beginning, if you catch it early enough, but then it transitions over to lymphocytes. The glucose tends to be normal, and the protein tends to be about normal, sometimes a little low. So a normal glucose with pleocytosis typically represents an aseptic or viral meningitis. TB meningitis, again, we think about TB meningitis in kids who are less than 2 and have pulmonary disease, so they have invasive disease. They typically have 50 to 500 whites. Their glucose tends to be low and protein tends to be high. So again, the protein glucose looks like bacterial meningitis, and this is a bacterial meningitis, but it's due to TB and not strep pneumo, not Neisseria. And the syphilitic meningitis, similar to TB with the number of white cells, but it's usually lymphocyte or monocyte predominant, low glucose and a low protein. Again, back to susceptibilities of pneumococcus, because the boards tend to like to ask about these. The susceptibility breakpoints differ between whether or not you have a CNS disease or a non-CNS disease, right? And the reason that matters is because the blood-brain barrier effect that prevents antibiotics to treat the infection from getting across the blood-brain barrier. And so typically you need a far lower MIC to be considered susceptible for CNS disease. So a lower MIC, which is a minimum inhibitory concentration. You don't remember the numbers. The numbers you don't need to remember, but just an FYI that susceptibilities depend on whether or not it's a CNS disease versus a non-CNS disease, right? Because for a non-CNS disease, usually the treatment can get to the site of infection pretty easily. So for bacterial meningitis, if the empiric therapy for a kid at least a month of age with a negative gram stain, you give a cephalosporin, a third-generation cephalosporin, so ceftriaxone or cefotaxime, plus vancomycin. So why do you give the vancomycin? All right, so resistant strep pneumo, right? So some people think you give vancomycin to these kids because of Staph aureus. You don't give it because of Staph aureus. Staph aureus doesn't cause bacterial meningitis in kids unless we do something to them. Remember, unless we give them a shunt of some sort, or we give them hardware, it's going to be strep pneumo. And we give vancomycin because the possibility of ceftriaxone-resistant strep pneumo. So you give ceftriaxone because most likely it's going to be sensitive to ceftriaxone. It crosses the blood-brain barrier relatively well compared to a lot of other antimicrobials, and it's cidal. You give the vanc on the off chance that it's a ceftriaxone-resistant strep pneumo. If the gram stain from the CSF shows gram-positive diplococci, that's suggestive of strep pneumo. So third-generation cephalosporin plus vanc. Again, Dex. On your boards, you give dexamethasone for Haemophilus influenza serotype B meningitis. Clinically, in real life, you can plus minus give it for strep pneumo disease if you know the organism. When you have strep pneumo and it's penicillin sensitive, you switch to penicillin. There's no need to give ceftriaxone for strep pneumo if it's pen sensitive. That's not using antimicrobial stewardship. If you have gram-negative diplococci, that's going to be Neisseria meningitidis, and so you use penicillin or third-generation cephalosporin. If it's pleomorphic rods, that's where you think about H-flu, and you give steroids and third-generation cephalosporins. If it's gram-positive rods, that's where you think about listeria, and that's going to be AMP and GENT. Gram-negative rods, so E. coli in a neonate, brain abscess due to Citrobacter, Enterobacter, you want to give a third-generation cephalosporin. And again, before the Hib vaccine, it was Hib for gram-negatives. Sequelae of bacterial meningitis. So the highest mortality is seen with staph. Again, that's usually associated with hardware infection, strep pneumo, gram-negative organisms, and then listeria. You have a very low mortality with Neisseria meningitidis. So one of my mentors used to ask the students and residents, if you had to have a bacterial meningitis, what would it be? And the answer is Neisseria meningitidis because the mortality tends to be fairly low, relatively. You typically can treat it with penicillin or ceftriaxone, and the duration is usually 5 to 7 days. Of all survivors of bacterial meningitis, the most common sequelae is hearing deficits. Okay. An 18-year-old college student presents with signs and symptoms of bacterial meningitis. LP is done consistent with bacterial infection, right? So consistent with bacterial infection meaning white count of the spinal fluid in the thousands, low glucose, high protein. She works in a daycare. Which of the following is the correct empiric therapy for the student? No antibiotics while you await cultures, IV ceftriaxone, IV penicillin, IV vanc, IV ceftriaxone plus vanc. All right, yeah. IV ceftriaxone plus vanc, right? Because you don't know exactly what this is going to be. So you give vanc for the resistant strep pneumo and ceftriaxone for strep pneumo, Neisseria, H flu. Perfect. Wow. You went at 5 o'clock, you guys are rocking. Strong work. Okay, so prophylaxis. Asymptomatic colonization is more common in household members, and so those are the ones you worry about the most. Again, similar to zoonoses, right? So it's the frequency of contact, the intimacy of contact. So household members, you tend to be frequently contacting them and intimately contacting with them. The risk of meningococcal disease is 500, 800 times greater in close contact, and prophylaxis is necessary for all household members and close contacts for Neisseria meningitis, and possibly necessary depending on circumstances of H flu. For prophylaxis, we typically give rifampin as the drug of choice for H flu. For meningococcal prophylaxis, rifampin in kids less than 18. If they're pregnant, you give them ceftriaxone. Aseptic meningitis, most common, that's due to a viral etiology. Again, most are enteroviruses. So you could also have a paroechovirus as well. Arboviruses, remember the mosquito-borne illnesses that we talked about. Mumps virus, LCMV, which we talked about from rodents, and herpes simplex. So again, the longer duration presentation, the weeks to months presentation of a chronic meningitis, you think of HIV, CNS disease, where either it's HIV itself or an opportunistic infection, a cryptococcal infection, TB meningitis. Again, with TB meningitis, you're gonna look at the MRI that shows basal ganglia enhancement of the MRI, histo, syphilis, or Lyme disease. If they give you specific terms on the vignette, namely swimming in a cow pond, you think amoebic meningitis. If they have chronic neutrophilic meningitis, think of nocardia, actinomyces, or some sort of fungi. Lyme meningitis will give you a Bell's palsy or a foot drop if they have CNS disease involvement. Brain abscess. So a CT scan is the way to diagnose a brain abscess. Sometimes we could do a biopsy if at all possible to get sampling. We typically don't need to do a lumbar puncture because it's not really indicated, doesn't really provide us a lot of useful information. The etiology of where the brain abscess came from, if you can tell, is very helpful in determining which antibiotics to use. So a frontal lobe from a sinus or sinogenic source, pneumococcus, H flu, sometimes MCAT, and anaerobes. From the middle ear, it's think about what causes otitis media, right? So strep pneumo, H flu, MCAT, sometimes Staph aureus if there's some sort of trauma. Similar to a neurosurgical procedure, you think of Staph aureus. For brain abscess, if possible, you drain. Sometimes it's not in a location where it's amenable to drainage, and you give antibiotics. If you're suspected of an MRSA infection, you give vanc. You also give ceftriaxone and metronidazole. The reason you give metronidazole is because metro has really good anaerobic coverage, and it crosses the blood-brain barrier pretty well. And so you always want to give metronidazole if you're suspected of brain abscess, because a lot of times from a paranasal infection, sometimes even odontogenic, it can happen that way from an anaerobic source. GI tract. So E. coli is the most common cause of bacterial diarrhea. You typically don't have blood. You typically don't have white blood cells. E. coli 0157H7 or the STEC, typically get from undercooked beef or raw milk. Again, HUS, hemolytic uremic syndrome. You can get it from fast food restaurants as well. Ooh. Okay, so a 12-year-old boy with underlying liver disease goes swimming in the Gulf of Mexico in Galveston, Texas. Why wouldn't you? He is scratched by the following animal, that thing. He develops lesions on his leg that quickly goes into DIC and has liver failure. Which is the most likely etiology for his serious illness? Cat scratch fever, crab scratch fever, Vibrio cholera, Vibrio vulnificus, or swimming in the Gulf with a dog? All right. Vibrio vulnificus. Somebody put swimming in the Gulf with a dog. I like it. And crab scratch fever. I like it. Yeah, so Vibrio vulnificus, right? What we talked about earlier. So seafood, shellfish. So cholera is what we think about. Cholera, right? There could be pandemics. Vibrio parahemolyticus is more frequently associated with shellfish outbreaks. And vulnovic is what we typically think about with skin infections and sepsis. A lot of times it'll give you the kid of a longtime local fisherman who scratches his hand on said animal and develops really rapid local disease infection cellulitis that translates into a systemic overwhelming infection. When you have someone who has liver disease or is immunocompromised, those kids tend to deteriorate more rapidly. If you see fecal white blood cells in your GI tract on a sample, you think of Shigella, Salmonella, Campylobacter, Yersinia, or amoebic infection. So C. diff, we said we're going to talk about C. diff a little bit. So the diagnosis of C. diff, you do stool, you look for white blood cells, and you do a stool toxin that now have 3 different available assays, so PCR, EIA, or cytotoxicity assay. Usually with the sensitivity we get now for our C. diff, you usually only need to do 1 stool test. The treatment is to first stop inciting antibiotics, right? So the risk factors include recent antibiotic exposure. You determine the severity, which unfortunately are based on adult guidelines. It's sort of the basis on some of the lab criteria that they have. So if it's mild to moderate, you give metronidazole for 10 to 14 days. If it's more severe or recurrent, you give vancomycin PO, which again does not taste very good. If it's complicated, where they're starting to have systemic symptoms from their enteritis, including hypertension or ileus, you give PO vanc, because again, PO vanc does not get absorbed systemically, so it's great for a GI infection, and you give IV metronidazole. And then if they tell you a vignette where a kid had C. diff and they gave them metro and the kid got better and resolved, but then the kid had C. diff again, use the same therapy as the initial therapy, whatever it was. If it was metro, use metro. If it was vanco, use vanco. Severe recurrent relapses, sometimes we use vancomycin and pulse doses over 42 days. So you start with a high dose, 125, 4 times a day, and then weekly you kind of pair that down to TID, BID once a day, every other day. Or you do vancomycin for 14 days, and then rifaximin for 14 days. And then you can also do a fecal microbiota transplant, which is becoming more and more commonplace in most centers. Okay, audience response. The best Star Wars film is Episode 4, A New Hope. Episode 5, The Empire Strikes Back. Episode 6, Return of the Jedi. Episode 7, The Force Awakens. Episode 8, The Last Jedi. Or other. I am a nerd, I mentioned earlier, and so I have to be a Star Wars fan. So I have to put a Star Wars question on there. Other? Really? Episode 1, 2, or 3? Come on. No, what? So we are going to about 9:30? I think it's, look, she said it. So we have to now. All right. I had my 4-year-old watch Star Wars for the first time the other day. It was kind of fun. Traveler's diarrhea. So E. coli, you can give bismuth. Loperamide is also effective. And you can also give Cipro or TAP-SMX at the first sign of diarrhea, which is recommended by most. Azithro is also a recommendation. Okay, so we mentioned this earlier. So 20% of a cruise ship's passengers develop a moderate self-limited diarrheal illness, not associated with eating any particular food. The water supply is not contaminated. No raspberries are eaten. The seas are calm. The only nausea-inducing aspect of the trip is that fish still hasn't finished their first gym session following down with disease. Which is the likely etiology for the outbreak? Right. So we should have about 90% correct, right? So this was one of the similar to a question we had before. Cruise ship, yep, cruise ship. Norovirus. Rotavirus is severe in infants. We now have a vaccine for it. And norovirus is a winter vomiting disease that we typically see on cruise ships. So remember, cruise ships, norovirus. Treatment. So you really don't want to give loperamide for diarrhea with fecal white blood cells, as it has a risk for complications. Sometimes you can give Cipro or TNP-SMX. Salmonella you typically don't need to treat unless they're immunocompromised or if they're less than 3 months of age. I think we're getting near the end because this is a question about Gilmore Girls. I don't know if anybody watched Gilmore Girls. My wife watched it. Of course, yes. The last 4 words presented a new arrival. So who do you think is the dad? No, no. Really? Kurt? I think Kurt? That's just funny. Sorry, okay. Asymptomatic bacteriuria. You treat it in pregnant women, neutropenic people, and transplant patients. Asymptomatic bacteriuria can happen anywhere between 1% to 6% of kids. It's asymptomatic bacteriuria, right? It means you don't have symptoms, and you typically don't have pyuria. And for UTIs, E. coli. E. coli, followed by some Klebsiella, followed by some Enterococcus. Osteomyelitis, acute infections, Staph aureus, MRSA, MSSA. It's more common in boys, more common in school-age children. Sometimes they have a history of minor trauma or a recent URI. Don't forget about Kingella in kids who are less than 5 and have a less severe course of it. Neonates, think of group B strep. They were gram-negative, Staph aureus, and group A strep. IV drug abuser, you think of MRSA and Pseudomonas. Puncture wound through the tissue, you think of Pseudomonas. And then sickle cell patients, Salmonella followed by Staph aureus. So again, bone and joint infections, skin soft tissue, Staph aureus, your group A strep. MRI is the imaging modality of choice. A bone scan is okay, and all it really does is exclude osteomyelitis. It doesn't necessarily diagnose it. You could do plain film, so sometimes they'll give you a vignette of a kid who had symptoms for 3 days, and one option is to get an X-ray, or they got an X-ray and the X-ray is normal. What do you want to do? And one option might be to do nothing because the X-ray was normal. Remember that it takes about 10 to 14 days for abnormality in the bone to show up on X-ray for osteomyelitis. If there's an abscess, you want to drain it surgically. And then for a prosthetic joint, you do a joint aspiration. And if there's a hardware, think of coag-negative staph. Remember, hardware, coag-negative staph. Coag-negative staph typically does not cause infection unless there's hardware, something foreign material in there. We treat osteomyelitis with IV antibiotics, usually for at least a few days, 5 days, 7 days, 3 days. It sort of depends on how well the kid is doing, and then we transition to oral therapy. Treatment should last no shorter than 3 weeks. Treatment failures happen for less than 3 weeks. Typically, we do about 4-ish weeks, depending on how severe the illness was, how many times they had to go to surgery, what their CRPs were, how well they tolerate PO, things like that. Again, empiric therapy is vancomycin for suspected Staph aureus. Sometimes you use clindamycin. Sometimes it depends on your locale. If your locale shows that you have Staph aureus resistance to clindamycin at about 5 to 10%, it's probably okay to do clindamycin. But it's closer to 40 to 60%, you don't want to use clindamycin empirically because half the time it's going to be resistant to clinda. You can always get cultures that show Staph aureus that's sensitive to clinda. You can go to it if it's MRSA. Septic arthritis, that's where you do a tap and then wash out. And IV antibiotic, it says 3 to 6 weeks. Typically, we do antibiotics for 3 to 6 weeks, usually closer to 3 weeks. And then usually it's IV to PO, similar to osteomyelitis. Discitis is a disease of toddlers, so low-grade fever, irritability, and they typically refuse to walk. They have back pain that worsens with flexions, and most kids, toddlers, don't complain of back pain. You can have deep tendon reflexes that are decreased. They usually have a lower lumbar involvement. In cultures of the blood and or disc space are positive about half the time, and it's usually Staph aureus. So discitis you're not going to see with a teenager. Discitis you're only going to see as a toddler. So you have narrowing of the intervertebral space on the MRI or plain film. MRI typically is used to make sure there's no concurrent osteomyelitis. Sometimes they recover without antibiotics, similar to strep pneumobacteremia. A lot of times they recover without antibiotics. But when you establish diagnosis, usually you want to do therapy against Staph aureus, so vanc or clinda. Bacterial endocarditis, right? So infection of the heart valve supporting structure. You do blood cultures. If you have negative blood cultures, you think of culture-negative endocarditis. Those can be due to yeast, so Candida, Coxiella, Legionella, or Chlamydophilus attachii. So some infection control notes, so outside of clinical ID syndromes. So standard or universal precautions are baseline for every patient who's admitted to the hospital. So you want to use hand hygiene and never recap safety needles. For isolation precautions, if they're airborne, that means that you're concerned about someone with TB, measles, or varicella, because they can be spread from very small particles. They're typically negative pressure rooms, and you need to wear N95 masks. So not just a surgical mask, but one of the N95 masks where you have to be fitted. Droplet precautions, so basically anybody during respiratory season. Coughing, sneezing secretions is where you can get some of the spread. Mask is required. If there are skin lesions, you can use gown and gloves as well, but these include things like meningococcus, pertussis, mycoplasma, parvo, group A strep, and influenza, and adenovirus. Contact precautions, so MRSA, so this is standard plus gloves. You don't really need a mask. This includes multi-drug resistant organisms, RSV, Hep A, rotavirus, and salmonella. C. diff, depending on your institution, at ours we call it contact plus. So I mean they have C. diff where you have to, again, what we talked about earlier, not use the alcohol-based gel or foam. You have to wash your hands with soap and water. All right, so some high-yield pearls, and then we're done. So BCG vaccine for TB is usually there to create shenanigans. Do not worry about it. Can BCG cause a false positive PPD? Yes. The sooner that you get the BCG and the PPD closer together, the more likely it is to have a false positive reaction due to BCG. But in this country, a positive PPD is a positive PPD regardless of BCG status. So do not worry about BCG status. If you want to test somebody who's at least 5 years or older, you can do the quantiferon, you can do the T-spot, one of the IGRAs, that we do a blood test for TB. Cephalosporins do not cover Enterococcus, not to be confused with Enterobacter. Enterococcus is gram-positive cocci, Enterobacter gram-negative rod. Cephalosporins have some coverage against Enterobacter, but cephalosporins do not cover Enterococcus. So if you're giving somebody ceftonir, cefixime for a UTI due to E. coli and they're not getting better, think that they have a UTI due to Enterococcus because the cephalosporins do not cover Enterococcus. Intracranial calcifications of the newborn, CMV or toxo. Rocky Mountain spotted fever, Ehrlichia or anaplasmosis over rickettsial disease, you give them doxy. If the mother has a history of maternal HSV, that puts baby at less risk for a neonatal HSV disease, less risk. The UTI diagnosis requires not only a positive culture of at least 50,000 CFUs per mil, but also pyuria. If the culture is positive with no pyuria and they're asymptomatic, that's called asymptomatic bacteria. In otherwise healthy kids, you don't need to treat that. A transthoracic echo is usually fine for kids. You don't typically need to go for a transesophageal echo when looking for endocarditis. Remember, an echo does not rule out endocarditis. An echo is helpful as one of the major criteria for endocarditis, but a negative or normal echocardiogram does not mean the kid does not have endocarditis. You need blood cultures. Oh, that's it. All right. So that's half of the talk. The other half went out. So no, thank you all very much for listening and being very patient and flexible. And this is very long, and I apologize for the duration, but thanks for listening.